Sure. अभिषेक एक मिनट के लिए ऑन कर लेना प्लीज वीडियो। So Neelam ji is multitasking. His team is out. Her team is out there, so she's alone multitasking. So
Abhishek Bhaiya, good evening.
Hello.
we are live, Supratik. Hello, we are live. Welcome everyone. A warm welcome to all of you, and it's a pleasure to see all of our family together. And we are going to have this National Obesity Conclave 2022, and we will talk about the relevance of obesity in Indian perspective and the relevant management that comes with it. Before we do that, we are going to have the formal inauguration ceremony. May I please request Ms. Neelam to formally inaugurate the session.
Vakratunda Mahakaya Suryakoti Samaprabha Nirvignam Kuru Me Deva Sarvakaryeshu Sarvada.
Thank you so much. So we are AMOS, Association of Metabolic Obesity Physicians and Clinical Endocrinologists, coming together for a noble cause. We know that obesity has become a pandemic that we are dealing with. It's an epidemic like diabetes. The global prevalence is on the rise, and so it is in India. And because of the relevance of obesity in Indian perspective, we are going to have an entire session. In fact, we're going to have 4 different sessions, along with panel discussions, answering all your queries regarding obesity, how to manage lifestyle, diet, exercise, and generally about therapeutics of obesity and management. So with this short introduction, I think we are going to start the session. I'll just take a second to put up my slides. It's just a couple of slides that I want to show ahead of the session. The way the things will flow is I'm going to introduce the moderators of the session, followed by the moderators introducing the speakers, and then we are going to have a panel. So we're going to have 4 individual sessions, and we are now going to start with the very first session. So just 1 minute till I share my slides. Have we done the photo, Neelam? Have we done the photo?
Yes, sir.
Perfect. Thank you so much. Please be with us, all the faculties, and we'll take it from here. Neelam, is my slides visible at the moment?
Yes, sir.
Yeah, Supratik, go on.
So this is a National Obesity Conclave 2022, and we are seeing a new era in obesity care. And we know that the world as we know it, it is built on story, but to be a change agent is first to disrupt the existing story of the world, and second, to tell a new story of the world so that the people have somewhere to go. So let's see what kind of perceptions do we have regarding obesity. and how with the changing concepts, we can build up on that or even change our perspective regarding obesity. And we're trying to answer the questions like, what is the current story of obesity and how does it need to change? So there are certain sort of thoughts that are there, and what we wanted to highlight is that obesity is not the act or process of eating or even gaining weight. It is the state of having too much of body fat. So this is a concept that we need to understand. At multiple stages during development, loss of baby fat, fat changes with puberty, fat changes with aging, fat changes with menopause, during and after pregnancy, the regulations occurs without a conscious or purposeful input. And obesity results from inappropriate regulation of body fat mass. So why obesity should be considered disease, and we are going to hear our colleagues talk about it in details, but we should know that it results from abnormal physiology, it causes pathology, and it diminishes health. Obesity also causes abnormal physiology and disease, and also a risk factor for other diseases. But it needs to be recognized, respected, treated, and prevented as a disease in its own right. So this is something that you come across very often, whether it's a heating, ventilating, air conditioning, where you have a thermostat, a sensor, where fresh air comes in and still air goes out. And what we have to do is, if your thing is too cold, then buy and install a bigger furnace, disconnect your air conditioning system, turn up the thermostat, and determine why it's too cold and correct the underlying problem. So with this thought, we will go into the sessions. Let us first have the slide of our moderators. I stop sharing here. The first session, can we have the first slide, please? So this is going to be our first session where we talk about obesity, an Indian perspective, and also benefits of weight loss. Can we have, yeah. So our moderators for this session is going to be Dr. Dhruvi Hasnani, and we know her very well. She's a great rapporteur, a great skillful orator. Is an MD Fellow of Royal College of UK and Fellow of American College of Physicians. Is also a part of RSSDI, is part Fellow, Pediatric Diabetes Consultant, Rudraksha Institute of Medical Sciences, Ahmedabad, and Treasurer RSSDI Gujarat chapter. And she has won many awards for diabetes, Faculty of National Diabetes Educators, and very, very progressive minded in terms of academics and research. Next slide, please. Our next family member is Dr. Vipul Chavra, and he's an MD, diabetologist and cardiometabolic physician, and he's done diploma in diabetes from Europe and diploma in diabetes, also a part of RSSDI, CCEBDM, chairman and founder of Rudraksha Institute of Medical Sciences, RIMS Healthcare, and district coordinator, Ahmedabad RSSDI National and Regional Faculty for Education of HCP's principal investigator on numerous trials, and many awards has been won by him, including Diabetes India USV Award for Best Diabetes Innovation, Excellence in Diabetes Awards from Times Group, and again, a very much academician and has a keen research interest. With this, I hand over the sessions to Dr. Dhruvi and Dr. Vipul, and they are now going to introduce the speakers and followed by a panel after.
So thank you so much, Dr. Supratik, and congratulations on a first inning of our AMOS group. And I welcome and congratulate all members on behalf of AMOS as well as RIMS. So thank you for the kind words, and without wasting much time, let's discuss about the obesity. What is Indian perspective and what we can do for our patients in our day-to-day clinical practice. So for our first session, our speaker is none other than the Thalaiva, the Arvinda. And to introduce him, he's MD Internal Medicine and he has a 3 FRCP and MRCP. He's a proprietor and chief diabetologist at Dr. Arvinda's Diabetic Care Center, Bangalore, India. He has a vast experience of working in various hospitals in UK, especially in the field of diabetes and endocrinology. one of the few with MRCP, with triple FRCP, and he is an award winner of Times of India Healthcare Achiever Award in the field of diabetes and endocrinology 2018. Bengaluru's highest civilian award he has won in 2018 and also received Diabetic Awareness Initiative Award in Diabetes India Conference held in New Delhi 2017. He has over 75 conferences, presentation, 30 publications, and involved in clinical trials conducted at Dr. Arvindas Diabetes Center. So we are proud to have him as a member of AMOS and as a first speaker of this conference. Over to you, sir.
Thank you, Vipul. Thank you, Supratik and the AMOS team. We are proud to have this association, and we'll move forward and march ahead with the better diabetes and obesity care, especially the obesity care. I'll share my slide. So I'll be talking about burden and phenotype of obesity in India and the benefit of weight loss. First of all, greetings to all of you from Bangalore. So I'll be talking on the gravity of obesity in India, that prevalence and trends, impact on health and prevention, benefits of weight management. So what is obesity? It's a chronic, relapsing, progressive disease process characterized by abnormal and or excessive adiposity that impairs adversely impacts health. It is associated with 200 plus complication, increased mortality, and reduced quality of life. It is right side, you can see very pictorially depicted the obesity and its complication. More than 135 million people with obesity live in India. I hope all of you agree on this. If you see, almost all the states are bombarded with obese people. So if you take the economic impact of overweight and obesity, currently India is at 99th rank in global preparedness to tackle obesity and overweight. By 2060, India will be spending 2.7% of the GDP due to overweight and obesity. So you can see genetic variants influencing obesity related traits in Asian population. Starting from left side, you can see natural selection, higher thermogenic activity of the brown adipose tissue, increased non-thrifty alleles in ancestor of East Asians, high susceptibility to central obesity. This is what we call as thin fat Indians at higher risk. You can see on the slide, left side is the non-Asian, right side is the Asian. So the Asian Indians have more fat, both total and in the abdominal region, with the less lean mass, skeletal muscle, and more bone mineral than all the other ethnic groups. You can see this. I'm sure you're aware of this cutoff points. Less than 18.5 is the underweight, 18.5 to 22.9 is normal, 23 to 24.9 is at risk of obesity, then 25 to 29.9 is obese 1, more than 30 is obese 2. But BMI and weight cutoff adopted by various countries, especially in Asia. If you take in India, the overweight is 23, obese is 25, and the waist circumference is 80 for female and 90 for male. So the rise of childhood and adult obesity is a big concern in our country. That's why we have formed this group, so that we educate the people. The childhood and adolescent obesity is becoming one of the serious health concerns. India ranks second among the childhood obesity. 14.4 million obese children, 15% overweight and obese prevalence. Childhood obesity by 2030, you can see at the age of 5 to 9, it is 10.81%, and 10 to 19 years, it is 6.23%. So what drives the obesity is an important question. First is the phenotype, second one is the urbanization, third one is the globalization, socio-cultural factors and food habits, and the fifth one is the genetics. So if you take the prevalence of complications with people with diabetes, obesity, 3% is stroke, 3.5% is the congestive heart failure, 8% is the ischemic heart disease, 9% is PCOS, 19% is depression, 21% type 2 diabetes, and 21% is MI, 29% is NAFLD, 35% is the GERD, 40% is sleep apnea, 51% is hypertension, 52% is the knee osteoarthritis. Life expectancy decreases as the BMI increases. It is depicted in this particular slide. You can see For normal BMI, almost 80% chance of reaching age 70 years. BMI between 35 to 40, 60% of chance of reaching age 70. BMI of 40 to 50, 50% chance of reaching age 70 years. Obesity negatively affects the physical, psychological, and sexual aspects of the life. You can see here on the first one, 100% increase in physical impairment in obesity versus normal weight. Psychological, 50% increase in psychological impairment in obese versus normal weight, 42% in sexual impairment in obese versus normal weight. So there is a potential lifetime benefits of early intervention. Early you intervene, better is the outcome. You can see early on the right hand side, you can see the earlier intervention could prevent earlier onset and later obesity. Late intervention may only have limited benefits, that is in the adult intervention. If you intervene in pregnancy, that has have a long way to go in preventing obesity. So the progressive weight loss has dose dependent and tissue dependent biological effect. It improves if you take the benefits of 16% weight loss, there is an improvement in liver insulin sensitivity, liver triglycerides, beta cell function, muscle insulin sensitivity, gene expression in subcutaneous adipose tissue, abdominal adipose tissue, adipose insulin sensitivity, and inflammatory markers. So the weight loss leads to improved health outcomes. That is, it improves hypertension, hyperglycemia, prevention of type 2 diabetes, NAFLD, PCOS, dyslipidemia, cardiovascular disease, urinary stress incontinence, NASH, obstructive sleep apnea, GRD, osteoarthritis of the knee, type 2 diabetes remission, CV mortality, heart failure with preserved ejection fraction. So it all depends upon the percentage of weight loss we achieve and the benefits achieved. Now over to the next sessions where we can further discuss about the further aspect of obesity by our esteemed speakers, so that at the end we can have a panel discussion. Thank you for your patience hearing.
Thank you so much, Dr. Arvinda. And before Dr. Dhruvi introduces Dr. Padik, I just wanted to say that our patron, Dr. Bansi Sabu sir, is traveling, is on the flight. So he said whenever he gets connectivity, he's going to, send a message of blessing to us. But in advance, he has already sent us wishes and blessings. So with that, over to Dr. Dhruvi. Thank you, Dr. Arvinda. It was a pleasure listening to you as always.
Thanks, Supratik. In between tasking.
So we've had a wonderful, wonderful first session of our very first AMOS, conference. And without much delay, can I request the RX team to display the
success story of how she would have been taking for the last 20 years. She's been taking insulin.
We know that Dr. Arvinda is multitasking, but can we request you to just mute yourself for a little while, please? All right. Okay. With that, can I request the RX team to yes, thank you. So now we have our second speaker, Dr. Rakesh Parikh sir. He is the fellow of American College of Endocrinology, the Royal College of Physicians, College of Physicians and Surgeons of Bombay, of RSSDI. He is the treasurer for RSSDI Rajasthan State Chapter. He is on the editorial and reviewer board of various journals. He needs not much introduction. He is a very dynamic, a great orator, a leader, and very recently elected into one of the very, very huge, essential positions for RSSDI. Over 50 publications, including textbook chapters. He is the PI for several global trials. So with that, Rakesh sir, can I request you to take over the stage, please?
Thank you, Dhruvi. Thank you very much for such a nice introduction. And first of all, let me thank Supratik for taking such an initiative of bringing us all together on one platform with a mission to handle diabetes. And Supratik, your efforts in keeping us together and doing activities regularly definitely deserve a big round of applause from all of us. Though the whole family is only here, but hats off to your efforts specifically for this. Now I'll try to share my slides. Just give me a minute. And thank you, Dr. Arvinda, for sparing time out of your conference. He is himself organizing a conference which is ongoing right now, but still he managed to be with us. I am not at a clinic right now. I'm in the hotel, so I can't have the background properly. So pardon me for that. Are my slides visible?
Yes, they are.
Okay, so I'll start with the second session of this symposium, which is on body weight regulation, the complexities and chronicity of obesity. As we all know that obesity is because of the imbalance in the energy balance of our body, which is normally maintained by human body. There is a mechanism by which the intake of energy and output of energy is matched. It follows the law of thermodynamics, which says that energy cannot be created nor be destroyed. It can only be converted from one form to another. So the intake of energy that we get is from the food that we consume, and the output is the energy that we spend in the basal metabolism of our body, as well as the activities that we do. And there is usually a balance between the two. But in case you consume more of calories and don't spend that many calories, then the extra calories are stored in the form of fat depots, so that you can fight in the stage when you are starving. That is the protective mechanism of the body, which was there through the evolution in our body. But unfortunately now we have enough of plenty of food and less of chances of exercising. So the major problem now is that the stores are getting more and more, and we are having the pandemic of obesity. So just to explain the same concept again, in the human body there is an energy intake which is from food, and the expenditure is in the resting metabolic rate, that the energy that is spent in the body even in the resting condition. Then the thermogenesis, which is diet induced thermogenesis, and then in the physical activity again there is non-exercise activity thermogenesis and the exercise induced thermogenesis. So overall this is the way you spend the calories. Now, this mechanism or this homeostasis is maintained very well in our body. So I'll request you to focus on the slide on the image on the left side. So if you can see in the normal humans, when you are fasting, when the stomach is empty, at that time, the stomach secretes ghrelin, and this ghrelin sends signals to the brain to eat more, or that is the signal for hunger. Also, the calorie expenditure is brought down because the body is into negative balance. You do not have enough of calories. So the signal is coming from the stomach that you need food, and that is why you feel hungry. But once you take food and it passes through the stomach to the intestine, immediately there are several hormones which are released from the gut, starting from the duodenum, jejunum, ileum to even colon. And these signals are again sent to the brain, and the signals tell the brain that we should now stop eating, and also give the signal for spending more calories in the exercise. And this is very well managed through different hormones. There are so many hormones that are involved. We'll talk about those in the next few slides. I'll try to simplify the matter. So in normal scenario, the appetite is regulated basically from the hypothalamus. There are two sectors in the arcuate nucleus. One is POMC, that is pro-opiomelanocortin, and CART, that is cocaine amphetamine related transcript factor. And the other one is NPY and agouti-related protein. So they both act in opposite to each other. So when the POMC axis is stimulated, then you feel satiety. When the NPY AGRP axis is stimulated, then you feel hunger. And they both inhibit each other. So the signals for satiety come from the gut through the PYY, GLP-1, and other hormones. They go to the arcuate nucleus. They stimulate the POMC and CRT axis. And the hunger signals, they come from the ghrelin. They go to the NPY and AGRP. And then this is for the short-term regulation of the energy. But in long term, when you have enough of fat depots in your body, at that time, leptin is released, insulin is released, and the higher levels of leptin and adiponectin and insulin, they send a signal again to the brain that we have enough of calories now. And that is what that is something like a satiety signal and the signal for increasing the calorie expenditure. Then this from here, the peptides that are released, they bind to the MC3 and 4 receptors. The alpha MSH binds to the MC3 and 4 receptors, and that leads to satiety, which leads to suppression of the appetite on one side, as well as expenditure of calories on the other side. On the other hand, if the signals are coming that the signals are coming from ghrelin side, then MPY AGRP axis is stimulated. It binds to the Y1 and Y5 receptors, which leads to hunger, and the calorie expenditure is brought down. It also inhibits the other axis. So this is how the homeostasis is maintained normally. In addition, in the brainstem, there are two regions, that is nucleus tectus solitarius and area posthuma, which are also getting inputs from the vagal afferents and the satiety peptides. And they also communicate with the hunger signals and the adiposity signals. And they decide our feeding and feeding behavior, the gastric emptying and metabolic rate. So overall, with this mechanism, this is the simplified version of this. There are many more factors which are involved, but this is how the energy balance is maintained normally in our body. So in addition to this homeostatic eating, which is eating for the hunger, we also have the this one is maintained through the mediated through ghrelin and the other hormones, as we discussed earlier. But in addition to this, we have hedonic eating, which is basically eating for pleasure, and that is basically mediated through dopamine, opioid, and cannabinoid receptors. So we eat for pleasure, even if the body doesn't require it. And then the function of the brain is also to execute or decide whether to eat or not. So this, the feelings and the thought process, and that translates to behavior. Behavior plays a very important role in maintaining the energy balance and avoiding development of obesity. And that is why the behavioral interventions are more powerful if you want to treat obesity. So again, just to come back to the same slide, the energy balance of energy intake and expenditure is basically managed through the CNS or the brain. But then there are other issues, other organs which are involved, like adipose tissue releasing the leptin, pancreas releasing the insulin, gut releasing several other hormones. There are genetic factors which are involved, which predispose a person for development of obesity. And there are several drugs which can predispose a person or which can lead to obesity in a person. Then there are environmental factors like the inactive lifestyle, smoking cessation, psychological factors, and increased palatability or availability of food for pleasure. So these are the different factors which are acting and leading to development of obesity. This is just to summarize the different hormones from the gut which are involved in this axis. Now, as we discussed, genetics play a very important role, and there are obesity is actually highly inheritable. We see that it runs in families. There are several genes involved in this. There are several SNPs which have been identified to predispose a person to obesity, and around 300 SNPs from 250 different loci have been associated with different obesity traits, as can be seen from this slide. So there are some traits which are responsible for visceral obesity, some are responsible for generalized obesity, BMI related, birth weight related, and so on. So among these, there are 97 loci. We basically act on the CNS expression, and they are responsible for the hypothalamic control of energy intake and regulating the body mass index. There are other 49 loci which basically decide the fat distribution in the body. So these are expressed in the adipose tissue, and they are basically responsible for the central obesity. So when you look at the different SNPs related to obesity, the majority of them affect the nervous system. In addition to genetic factors, we also have environmental factors. So socio-cultural factors, the traditions, beliefs, and the peer pressure, which is very important nowadays. If you talk to your kids who are going into the school, you realize that there is a lot of peer pressure. My classmate is eating from the canteen, so I want to eat from the canteen, and that kind of peer pressure is leading to the excessive fat, fast food consumption in the children. Then there are socio-economical factors. People are not having enough of money, so they don't get the healthy food. They just get to eat a lot of carbohydrates, which also lead to obesity. Food environment is changing. We have plenty of food now, and most of the available food is unhealthy, though it is available very fast and cheap. The availability of inexpensive and highly palatable food is also a responsible factor for the pandemic of obesity. So as we have seen earlier, the body tries to maintain this homeostasis of energy balance so that you don't get obesity or you don't put on weight, and you can fight the starvation also through so many different neurons and other factors which are involved in this process. But then because of the several environmental factors which are currently active, like the media, the education, the technology, the nature of work that we are handling nowadays, and the early life experiences, food production and supply, so many factors are involved, and all these are leading to the pandemic of obesity that we are witnessing currently. Now, there are a few questions which still remain unanswered. I'll just try to address a few of those. So as we all see that it is very difficult to maintain weight loss. So even I myself lost a few kgs few days back and regained those kgs again. So rebound weight gain is a very common phenomena that we see very often. So how do you explain that? Now, this has been seen in different studies. So these are all the different trials in which people have seen that they have lost significant weight. In some of these, you can see that there has been a weight loss of around 20 to 30 kgs. But once the intervention is stopped, and if you observe the patient in the follow-up period for 4 to 7 years, you will see that most of the lost weight is again regained. And sometimes the patients even get excessive weight, which is beyond their baseline weight. The same is seen irrespective of the diet that you follow, whether you follow the very low-calorie diet or the modified diet plus behavioral therapy or the VLCD plus behavioral therapy. After a gap of few years after intervention, the baseline weight again comes back to the same. So Supratik showed one slide in which he was mentioning about thermostat. So that time I thought he's probably going to talk on this. So basically now there's a hypothesis that there is a kind of such thermostat. Thermostat is a term for maintaining the temperature, but there is some set point in the hypothalamus which basically keeps your weight at the same. So whatever weight you have been meant to have, the body tries to bring down the weight to the same. So even if you are an obese person and if you lose weight, the body tries to bring it back to the overweight side again. If you are a lean and thin person and you try to gain weight, then the body tries to bring you back to the lean side. So that is what is a hypothesis, and there is evidence to support that. So whenever you try to lose weight, the body will try to increase the energy intake and suppress the energy expenditure. So the obese people, if they lose weight, their body will modify in such a way that they will try to eat more and the energy expenditure will come down. And there is evidence behind that. So this was a study in which they have seen that people who were obese lost weight. In their blood, if you look at the leptin levels are not that high compared to the people of the same weight, but who did not try to lose weight. And in these people, if you give them leptin supplementation, then they can maintain weight. But if you remove leptin, then they will again regain the weight. There's another evidence which is looking at the energy expenditure in the people who have lost weight. So once you lose weight, your basal energy expenditure goes down significantly, and that is how the body tries to bring you back to the same level. So this was regarding the the hypothalamic set point for your weight. So whenever you try to lose weight, the body will try to bring it back, and we need to fight with that. And it is not very easy. In this particular trial, they have looked at the people who were on sibutramine for weight loss, and after a period of 6 months, the people both the arms were on sibutramine. They lost weight significantly, but after 6 months, one arm was left on without medicine, only on diet and behavioral therapy. The other arm was kept on medicine in addition to behavioral therapy. And they observed that the people who were on medicines, they could maintain weight, but the people who were off medicine and only on behavioral therapy, they again came back to the baseline weight. Now coming to the second question, just hint me if I'm going beyond time. Okay, so why some people are prone to obesity while others aren't? So we see that there are people who are obese, and despite them trying their best in terms of low calorie diet or restriction in the diet as well as exercising, they find it very difficult to lose weight. And there are people who are very lean and thin, who eat a lot, who do not exercise at all, but they don't gain weight. So why is there such a difference? So basically, among the axes that we discussed earlier, leptin is the hormone which is responsible for long-term maintenance of weight. And leptin basically acts on the agglutinated AGRP neurons as well as on the POMC neurons. So when leptin is activated, at that time, POMC neurons are activated, and then there is a message to the brain that you don't need to eat more or you need to spend more calories, and that is again through MCR4. On the other hand, the AGRP neurons, there also leptin has the effect of inhibition, and that also mediates through MCR4 receptors, the same receptors. And ultimately, the activation of these receptors goes to BDNF, which is brain-derived neurotrophic factors. And if you look at the BDNF gene, then there are different alleles. So there are people who have the TT pair of the TT allele of BDNF gene, and there are others who are having CC allele, and there are others who are having CT. So if you are having TT, TT kind of BDNF gene, then you are predisposed to be on a leaner side. And if you are having CC kind of gene, then you are having the tendency to put on weight or to be on overweight side. If you have a TC, then you are intermediate in between these two. And that is how genetically people are predetermined to be on overweight side or on the leaner side. Now the third question, what is lean obesity? So we always talk that we are lean and obese people. Indians do not have that much of BMI compared to the Europeans or Americans, but then we still are metabolically unhealthy. So this was an animal experiment. On the left side, there is a graph in which you will see yellow and green bars. So these were the rodent models, and they were given, there were two groups. One group was given low glycemic index diet. The other group was given high glycemic index diet. and the objective was to maintain their weight comparable. So both the groups had the same weight irrespective of what they are eating. Now, when you look at the right part of the left graph, then you will see that even if their weight was maintained as the same, the people who were taking the higher glycemic index diet, they were consuming less calories. So even if the weight is maintained same, if you are taking high glycemic index food, then you have to restrict on your calories. On the right side, if you see, when you analyze these two groups, even if their weights are identical, the people who had a high glycemic index diet, they had more of adiposity. So their weight was mainly because of fat tissue. Whereas the group which had a low glycemic index diet, they had the same weight, but that weight was lean body mass and it was not fat compared to the other group. And the same was seen on the on the left side. If you see, this was the autopsy of both these groups of rodents, and they both have the same weight, but their the weight of the people who had a low glycemic index, the rodents who had low glycemic index diet, was mainly lean body mass, whereas that of the high glycemic index diet, they had a fat mass which was more, which is analogous to the YY paradox that we all seen, Yudkin and Yachkin paradox, in which they both had the same BMI but different distribution of fat, and that is also explained by our diet, which is actually high in carbohydrates and probably high glycemic index food that we consume.
Okay, sir. Sorry to interrupt. Can we?
Yeah, just
in 2 minutes. Yeah.
last 2 slides. Yeah. So then, does the in utero environment have any role in obesity? So if a mother is obese, then in her body, large amount of free fatty acids are released, and those go through the placenta to the fetal circulation. The fetus is exposed to large amount of free fatty acids, which leads to fetal inflammation and genetic makeup changes, the programming changes, and these children are at a higher risk of getting obesity as well as the other associated conditions. And this is a trial, very interesting study. So in this study, there are two groups. Basically, there is a single group. These are the mothers who were obese earlier, and their children before surgery and after surgery were compared. So the mother who was obese, she delivered a baby. After that, she went for a weight loss surgery, and then she became pregnant, and then she delivered the second baby. So these two babies were compared. And if you look at this, then the same mother, when a child is born when she is obese, and a child who is born after the surgery for weight loss, these are totally different children. Their birth weight is different, their body weight is different, their body fat percentage is different, their insulin levels are high, their glucose levels are high if the mother was obese when she conceived that child, which explains that the maternal uterine environment plays a very important role in development of obesity. And the last slide of mine, what is the role of gut microbiota? So I will not go into details of this, but if you compare the microbiota of normal individuals and obese individuals, you will see that it is totally different. The microbiota in normal people improves the insulin sensitivity, reduces inflammation and severity risk compared to the microbiota of obese people, which increases insulin resistance, causes dyslipidemia, also increases the cardiovascular risk. So there have been trials to even try using the fecal transplant of lean people into the obese people. Some trials have been positive, some trials did not show any result. So this is still the area on which work is going on. So obesity is not that simple. It's not just the factors. There are so many factors involved. There are so many hormones involved. There is a environmental factor involved. And I just try to summarize all these into 15 minutes. Thank you all for the patient listening.
Thank you so much, Dr. Rakesh. I think you did a brilliant job. You brought a lot of good pointers regarding the basic pathophysiology of obesity, which we need to understand if we want to deal with obesity. Now, may I please ask Dr. Rakesh, Dr. Arvinda, Dr. Dhruvi, and Dr. Vipul to join as a panel. And so I will start off by asking the first question to Dr. Dhruvi, that we know that Indians as a phenotype, a thin fat phenotype. So what are the concerns and considerations that we should have when we are dealing with this population?
Thank you so much for the question, Dr. Supratik. There was a beautiful slide in Pariksa's slide deck where he showed the YY paradox. And he did talk about the thin fat Indians into that with the same amount of BMI, we Indians, we still have a higher fat percentage into our body, which puts us at a higher risk of getting the same non-communicable diseases, be it type 2 diabetes, be it diseases arising from the common soil of endothelial dysfunction at an earlier age in comparison to our Caucasian counterparts. So the concerns remain that even with a BMI of say 25 or 26 or 27 also, which are just an overweight limit for people who are Caucasians and Europeans and the whites, we Indians are at a higher risk of getting type 2 diabetes, of having hypertension, of having cardiovascular diseases, and every other non-communicable diseases arising from the soil of endothelial dysfunction. And we have to keep it into consideration that 23 is our BMI cutoff, and which is 25 for the rest of the world. We are Southeast Asians, and not just thin fat Indians. We have to also consider our genotype, which again Dr. Parekh sir illustrated quite well. That we have a thrifty genotype, and again it is putting us at a higher risk of getting all of these non-communicable diseases at an earlier age, which means we'll get the complications at an earlier age.
Perfect. Perfect. Thank you so much, Dr. Dubey. And the next question goes to Dr. Vipul. So what is the status of awareness about obesity in our population, and how do we go about improving the same?
Yeah. So the status of awareness in our country, what I am observing since last 3-4 years, post-COVID, the status is improving. As we all have witnessed the pandemic, and we see that during the pandemic, not the patient who has diabetes, not the patient who has hypertension, not the patient with cardiac history were suffered more, but the person who has obesity were suffered a lot. And the obesity leads to not only the discomfort in the life of the patient, but also brings other disease like diabetes, hypertension, kidney disease, and osteoarthritis, osteoporosis, as well as some cancers can be relate with the obesity. So there is a beginning of the era where the people as well as the clinicians are getting aware about the obesity. And this is the MOS is one of the hallmark of the thing that people are getting into the obesity thing. And we are aware, we are making our patients aware, and we are doing something for the clinician, endocrinologist, diabetologist, and our patient to reduce this burden of obesity in our country.
Perfect. So before we open this up for all of you to ask questions, I just want to ask, I think we have addressed some of this, but going back to Dr. Rakesh, so we already mentioned probably there is a myth regarding obesity is all about eating too much, and we were trying to address that fact. Along with that, you have already mentioned why weight loss initially is easy, but to maintain that weight loss is very, very challenging. So what are your comments on that, especially about the fact that our concept regarding obesity is all about, probably I'm doing something wrong, I'm eating too much.
Yeah. So basically, that is, Supratik, a very important factor. Even I myself did that mistake. Whenever the patient comes back to you for follow-up and he doesn't lose weight, we actually try to blame the patient that you must have done something wrong. You must have cheated on your diet. You must not have exercised. But then going through the good thing that you've done with MOS meetings is that we started reading about the pathophysiology of obesity. I myself never read it in details that I did for the presentation. So now we started understanding that actually it's not the patient's fault. He is genetically programmed to be overweight or obese. And we need to do a little more than just calorie restriction. One of the thoughts which is very important is that it's not only the calories that you consume, it is the quality of food that you consume. So different type of food have different effect, and that decides whether you go on the overweight side or you lose weight. So just to give you an example, like the same discussion that Dhruvi and you were having earlier, the problem with our diet is that it's very rich in carbohydrates. So the high carbohydrate diet is probably the culprit for the lean fat type of obesity that we have. So we must start focusing on the type of food or the quality of food that we consume from the childhood, and probably that is the way we can try to tackle this pandemic of obesity, which is now so rampant that you see all the school children, they are putting on weight since that age. And that can only be addressed by creating awareness, as you rightly said, which is still lacking, and focusing on the quality of food that we consume, and giving some more time to the children for exercise and play.
Thank you so much. Going back to Dr. Dhruvi again, and I think this is another very pertinent question. So when you talk about weight loss, we need to give them some pointers regarding what kind of weight loss is going to be beneficial for them. So what is your suggestion to your patients? Dr. Dhruvi, you're on mute, please.
All right. So, this is the confusion when you have two systems in the room. So you have to keep it in mind which is mute and which is not. So now back to your question. There's a beautiful slide which we have, repeatedly shown everywhere. And I get it that it comes from one of the landmark trials, that if you have 5% of weight loss, there is control in your hyperglycemia, there is control in your hypertension. If you have 10% of weight loss, you have dramatic improvement in your NFLD status, in your, cardiovascular risk score, ASCVD risk score. You have dramatical improvement in your glycemic variability. If you have 15% weight loss, again, it talks about benefits in OSA, it talks about benefits in NASH, it talks about benefits and sort of a remission in hyperglycemic status. So we generally give a target to our patients that, there is not everything is possible for everybody, but we do explain that this, if you are able to achieve in a given period of time, then these are the benefits that you will get. But again, how we achieve that is another very, very important thing. Lifestyle modification is number one. And the amount of weight loss and the benefit that we are talking through our session, it has to come both from weight loss as well as weight maintenance as well. So I think I'm answering your question. When we have to talk about weight loss and its benefit, we have to keep a particular target for different sort of patient and individualized target. Not everybody can achieve a 15-20% of weight loss, but of course the 5 to 10% of weight loss is possible, is beneficial in terms of achieving a good glycemic control, a good hypertension control, as well as control in terms of fatty liver and OSA.
Perfect. So two more questions. Last but one question goes out to Dr. Vipul. So my question will be, what do you think is the most effective way of managing weight or reducing weight? So what is the advice that you give to your patients?
So first of all, we are making our patients aware about the situation of what BMI is he or she is having. And we explain that what percent of the weight if he or she loses and what are the benefits they will get. We more emphasize on explaining them and educating them that obesity is not a physical disorder, it is a mental disorder. They have to be aware of the situation and they have to do a proper intervention in their lifestyle in terms of diet modification, in terms of scheduling their exercise, in terms of looking the quality of the food, of what they are eating. And we also explain them about visceral fat as well as the subcutaneous fat. The visceral fat around the viscera are more dangerous because they can lead to insulin resistance as well as micro level of inflammation that can lead to endothelial dysfunction. So we educate our patients family as well as make them aware of the benefits of the weight loss, and by that we promote the weight loss in our patients.
Perfect. So last concluding question to Dr. Rakesh, and this is about the barriers that we come across in weight loss. So what do you think are the barriers that come in the way of weight management? Dr. Parikh, you need to unmute yourself, please.
So before I address that question, I think I'll answer the question put by Dr. Mahua in the chat box. She has asked, is there a role of timing of diet in weight loss? So that is again a very important topic, and it's being debated. I'm actually debating on that topic probably in RSDA conference, whether time-restricted diet has any role to play. Now, I actually wrote an article 2-3 years back. Basically, there was a fad in Maharashtra about some person, a diet named in his name, that if you eat only for particular hours of the day, you will lose weight. and which is right. But then the mechanism that he explained was not correct. So basically, if you are fasting for a prolonged period of around 14-16 hours, then your body goes in ketosis, and that is how, if you're in ketosis, you will not feel like eating and you will start losing weight, and ketosis itself causes weight loss. So this time restricted diet basically works just like a the keto diet, and it definitely helps you. But in long term, it may not be possible for a person to maintain that, and then probably again you will have the rebound weight gain. The second question that Supratik asked is about the barriers. So the commonest barrier that I face in Rajasthan, Jaipur, or North India, probably Dr. Mindal would agree with me, that there's a lack of awareness. When we fortunately now have drugs which give some good weight loss in patients, if we prescribe those drugs, if a patient is overweight or obese, if I bring down his BMI from 29 to 27, he comes back, Dr. Sahab, मैं तो बहुत दुबला हो गया हूँ. And people have started blaming me, क्या हो गया, तुम्हारा चेहरा उतर गया, ये हो गया. So I need to tell that person that अभी तो 27 तेरा BMI है, 28 BMI है, you are still obese, you are obviously obese, and that's not good for your health. But it's really difficult to convince people that losing weight when you are obese is actually good for you. So that is the stage where we are right now in Rajasthan, at least. Maybe in metros like Delhi and Mumbai, or maybe among the youngsters, there is a awareness. So probably the first hurdle is to convince people that you need to lose weight and what is your ideal body weight. The second hurdle that comes is, people try to lose weight and then they fail, which is very common. And so somebody who has tried a few months and did not, get a significant weight loss, or somebody who has regained weight after loss, he is actually lost hopes. So to motivate that person is really difficult. He will always tell you, Dr. Saab, I have tried everything. It doesn't work. In my case, nothing works. So you need to actually motivate that person and then, educate him again and do some behavioral therapy on that person. So that is really challenging in some cases, but we must not give up and we must try. So I think these are the two hurdles that I face.
Perfect. No, I think it's always a challenge because every single patient is different, and you'll be surprised. One patient just walked into my clinic and she never realized that weight was an issue. And the husband specifically said, I love my wife the way she is, so I do not want her to lose any weight. So we need to assess their requirement before we jump in and educate them regarding weight loss, because that might not be appreciated. But we will come to know about, we have already talked about diet, exercise, lifestyle. We'll be talking therapeutics just now. So we'll conclude this session. Thank you so much, everyone, for contributing to this session. We are going to conclude this. Before that, a felicitation for all of you, please. A big round of applause.
Thank you. Thank you, Supratik. Thank you, everyone.
And these mementos will be reaching you very shortly. Thank you. Thanks a lot. Okay, now moving on to the second session. We have the moderator slides, please. So this is going to be a panel discussion. And at the end, but initially we'll have two talks. This will be moderated by Dr. Amit De, who is MD, Diploma Geriatric Medicine, Diploma MSc Diabetes from UK and FRSPH UK. And he's a consultant physician in diabetology, obesity, and metabolic disorders. He's my dear colleague and friend from Kolkata. And he's at Apollo Sugar, Apollo Clinics, and Eden Health Plus. He has experience of 10 years into clinical practice with diabetology as primary subspecialty, winners of Diabetes Awareness Initiative Award in 2020, and fellow of Royal Society of Public Health, member of RSSDI, ACE, ACP, etc. Early career physician council member for ACP. And he has also been associated with various patient awareness programs, healthcare training activities, etc. Presented many papers and posters in various national and international conferences. He has participated as a speaker in various national, international conferences. I know him personally. He's a very good organizer, and it's always nice to have him on board. So with this short introduction, can we have Dr. Mahua's slide, please? Again, a very dear friend of mine, Dr. Mahua, is a consultant diabetologist. He's a director. She's the director of Chennai Diabetic Clinic, Bardhaman. West Bengal, and she's the winner of RSSD Award of Excellence in Diabetes Care 2019 for West Bengal State Chapter. She's been a speaker and faculty at various national conferences. Her special interest lies in GDM, type 1 and childhood diabetes, and also about the congenital hyperinsulinemic hypoglycemia in annals of human genetics. And she has been actively working on various diabetes awareness programs in the country. And now I would request the moderators to now go and introduce the speakers for this session.
Thank you very much, Dr. Supratik. Introduction, and congratulations to you for setting up this platform where we can actually, take up obesity as a topic, discuss and tailor-made, the line of management for our patients. So without wasting much time, after a wonderful first session, let's go on to our second session. And let me introduce the first speaker. We have with us Dr. Anubha Verma, and she is an MBBS, MD Medicine, MMSc Endo, FSCP, FR, CPE, Finch and Fellow of UDPA. She's a professor in the Department of Medicine at MLN Medical College at Prayagraj. She has 4 gold medals and 22 certificates of honors in MBBS. She's also leading the ACP Wellness program in the ACP India chapter. She has been awarded the ACP Wellness in 2021. She has also won various other awards, and just to name a few, the ACP Wellness Champion 2022 and 23, Investigator of the Year in 2018 in ISH at BPCon 2018. She's also won the Women in Medicine Appreciation Award by ACP in 2021, and she is the Diabetes Education Foundation in the member editorial board. She has multiple publications, both international and journal, and she has more than 20 book chapters. She has also organized various conferences as an organizing secretary and scientific secretary. So with this introduction, I will hand it over to Dr. Anubha Verma with the topic.
Thank you, Dr. Amit, for kind words. And I would congratulate Dr. Supratik for such a great initiative of organizing such a wonderful conference, I should say, and on a very pertaining issue of obesity. I would like to say it is a new diabetes. Whenever we used to talk about diabetes, it is a coronary heart disease equivalent. Now, when we talk about obesity, we'll be talking not of obesity, it is a diabesity, or obesity is a problem. So I'll be talking on the obesity and the cardiovascular risk, what the learnings have been there from the cardiovascular trials so far. So I'll take next few minutes. I'll just. So just we had a very great first session, and it was very informative. I'll just in few minutes I'll just go towards my flow. You do you know this person? He is a very famous goalkeeper. Anyone can guess his weight? He has been famous for his weight. He's Daniel Lambert. He was very famous for his weight of around 335 kg. He died at an age of 39. And yeah, obesity is definitely a menace then and now. So Dr. Rakesh very well talked about the pathophysiology. So it's just not the imbalance, it's much more about the fat cells. If we talk about the obesity, it is actually an independent risk to all the factors of the metabolic syndrome. Talking about obesity, all fat at any point of the body looks bad, but yes, the males tend to have an apple shape and females tend to have a pear shape. This has been addictive, and the differences in body shape to a larger extent explain the difference in the CHD risk. But as we see nowadays, now people, even the females are having more abdominal obesity, more apple shape, and hence the change in the paradigm shift in abdominal obesity in them, having so many gynecological problems in them, and definitely increase in the heart disease risk. So obesity is a global cardiometabolic risk. This visceral adiposity or abdominal obesity is responsible for insulin resistance to begin with and resulting in beta cell defect to the diabetes and its complications. We were talking about fat deposition. So this fat, specifically the intra-abdominal fat, as we were discussing the pathophysiology, causes the elevation of so many inflammatory mediators and hence is responsible for the increased cardiovascular risks. So we also discussed about the fetal programming. So not only the genetic makeup is responsible, the environment sets in, and hence the interplay of the many factors is responsible for obesity and the other factors associated with metabolic syndrome. The intra-abdominal obesity is actually responsible to be the cause of increased metabolic risk due to association with inflammatory markers, elevation of free fatty acids, decreased adiponectin level, and hence producing a state of insulin resistance. If this pathophysiological risk link there is a link between the cardiovascular disease and obesity, it's a two-way process. The obesity and the cardiovascular disease. We've talked about the adipokines and adipocytokines in the insulin resistance resulting in the cardiovascular diseases. So raised blood pressure, the raised weight, the higher BMI is responsible for rise in blood pressure, rise in blood glucose, rise in insulin resistance with elevation of blood lipids and inflammation and hence formation of plaque, and responsible for the atherosclerotic cardiovascular disorders. So this was the one which we were talking about, the endothelial permeability, enhancement of insulin resistance, decreased glucose uptake, and lots of elevation of the inflammatory markers, which is responsible for from the lean adipose tissue to the conversion of the obese adipose tissue. So the problem lies in the increase in the fat cells. Talking about the adiposity, it is, as we were discussing, the various mechanism, enhancement or activation of the RAS to the sympathetic nervous system, to the lipid enhancement of the production, to the adipokine synthesis. There is increase in the GERD group of disorders, in the bone disorders, obstructive sleep apnea, as Dhruvi said, the liver, the NASH, which is a newer burning topic, type 2 diabetes, the coronary artery disease, the heart failure, and hence we have discussed the various complications of obesity, ranging from the cardiovascular disease to diabetes to apnea, obstructive sleep apnea, to a thrombotic state, to depression, anxiety, where you lost your self-esteem, to NFLD, and infertility, incontinence, specifically in females. So the increased BMI lead to around 4 million deaths in 2015, with more than 2/3 from the cardiovascular disease. So association of body mass index with lifetime risk of cardiovascular disease and compression of morbidity. This was one of the article published at JAMA in 2018. I'll take you back to time of 1990s. This is one of the paper published way back, which has shown this is the nurses health study, which was done for an 8 years follow-up, around 5,000 patients. It was shown there is risk of non-fatal MI and coronary artery disease as the BMI increases. During the 16-year follow-up studies, it was shown this risk increases steadily from BMI about 22. Also, they found the waist circumference has been shown to be independently associated with the age-adjusted risk of coronary heart disease, even after adjusting for BMI. So now BMI is important. The waist circumference is again important. This is a Framingham study, which was a maximum longer study for around 26 years. And they too correlated the incidence of cardiovascular disease with the relative weight. With the increasing weight, the disease the association of cardiovascular disease increased. The Honolulu Heart Program, a 12-year follow-up program, also have an association of subscapular fold fat with as a measure of central adiposity. The HOPE study, which pointed out the patients were divided according to the waist circumference into the 3 tertiles. Here, the abdominal opacity was as the abdominal opacity increased, there was increase in the risk of cardiovascular events. Yet another study which was published in JAMA way back in 93 also showed the similar effect of waist hip ratio and BMI. This was one of the Gothenburg, Sweden study. It showed the male and female incidence of the coronary heart disease is mainly linked to one factor, that is the waist-hip ratio. When this waist-hip ratio is adjusted, the 6 difference in the CHD risk disappears. So this is a better marker just than the BMI. As we have seen, the Caucasians and the Asians may have a same BMI, but they have a different abdominal fat. So there's a list of studies which we have discussed: the Framingham Heart, the Nurses Heart, the Gothenburg, the Iowa study, which all have showed a linear association of the increasing body mass index to the coronary artery disease. The newer studies, the Iowa and the Gothenburg, were also able to show an independent association of waist-hip ratio with the coronary heart disease or the heart diseases as per se. So if you see the males are more than 30% more associated as compared to their counterpart female. It may be one of the reason I told you the type of obesity which is seen in male and female. The abdominal obesity is more commonly associated in the male, but the changing in their lifestyle, the eating pattern, the lifestyle problem has changed the shift the females from the gynecoid obesity to the android obesity, and that is the problem which is seeing more heart disease problem, more NFLD problem in these group of population. Not only this, our gynecological counterparts are also complaining because they are having the shorter pelvis, they are having lots because they are obese, the problem of PCOS, the problem of infertility, the higher risk of malignancies, all may be associated with this change in the pattern and hence obesity in females. So some of the cardiovascular studies which were done on the obese patient, which by the effect of the weight loss, is one of the study of Look Ahead. It showed when there was reduction in the blood pressure, triglyceride, HDL and LDL, the incidence of cardiovascular mortality is reduced. As you can see, this was a 23-year follow-up study, and there was significant reduction in the cardiovascular mortality by reduction of weight as well as the other metabolic parameters. As Dhurvi was telling about the percentage of like 5%, 10%, more than 15%, where we talk about diabetes reversal as per se. Yes, this study also showed similar that at least 10% of the body weight earlier, if it was lost, this provided the reduction in 21% in the primary outcome, that is the non-fatal acute MI, non-fatal stroke, and the admission to the hospital for angina, and there was reduction in 24% for the secondary outcome also. But the question rises how much it can be maintained on a longer time, because regain of weight is a bigger issue. Role of anti-obesity medications from these trials, though we'll be having next session on the pharmacological management, but I'll just have a brief review regarding the anti-obesity options in the adjuvant to the lifestyle modification. So you see the lifestyle holds, which has been shown by the DCC trial, the earlier trials, has very significant or the independent effect other than the drugs in not only reduction of weight, not only reversal of the glycemic status.
Very sorry to interrupt you. We are getting a little late.
Sure. I'm just winding up. So what we need to do is we see the trials. There are the progress of the obesity. If you see the trials, so we have the various trials with the drugs which are available, the sibutramine, rimonabant, naltrexone, and locazepam. So majority were terminated because of enhancement of the cardiovascular problems, and the sibutramine was harmful, and hence there is very less medications which we can provide. It should be in association with a lifestyle modification. The cardiovascular benefit by the GLP-1 analog. So there are lots of studies, the RCTs, which has been done, and they have proven to be having a great weight reduction potential. A word regarding the SEMA, which is one which is there, newest addition to the GLP family, and the pioneer study, the sustain study have shown a better their profile, not only in diabetes and weight control, and we are waiting for the Ozempic, a single dosage injectable to be approved for obesity. So obesity is associated with increase in heart risk failure, and talking about the SELECT trial and the STEP trial, the role of semaglutide is known. Hence, to summarize, obesity is changing the cardiometabolic landscape. The cardiovascular risk can be reduced in people with obesity through weight management. Substantial weight loss is now possible with novel drugs like GLP-1, and weight loss could be considered as a key treatment targets for cardiovascular benefits. So I've given you the details, I've given you the data, and hence we are very well sure that weight reduction is the crux or the root cause or the mother of all problems. So if we talk about the metabolic diseases, we need to work there. Nothing, we cannot say everything works for all. It has to have an individualistic, target-oriented approach. Thank you.
Thank you, Anubha ma'am. It
So
was a
much,
great.
Anubha.
Yes.
Back to Dr. Mahua for introduction of the next speaker, please.
Yeah.
Great job, Dr. Anubha.
Thank you.
Yes, our next speaker is Dr. Bharat Sabu. He is a chief diabetologist and director at Prayash Diabetes Center, Indore. He is trained in data science for precision medicine from Edinburgh University.
Thank you.
Yes.
An introduction. Can we move ahead? Because
Yes, definitely.
Thank you. Thank
Yeah.
you. And before that, I would like to thank my dear friend, my brother Supratik, for putting this up. Actually, we are still remembering that day of 11th of March. I hope everyone remembers it, when we were together, and this little kid was born in our mind, and we first showed it to the world. And now from there, we have reached here. So it feels really great to be part of this. And because when you see the journey of something growing up, it makes so much sense. So I would be very crisp, and I will be sticking to my time, which is allotted to me.
May I also say that the Facebook page of Amos was created by Dr. Bharat Sabu, and we are live on that page. So we are going to grow together.
Sure. We are all here and we are together. So we are again together against this menace, which is obesity. And now I will be talking about this interplay, like the interplay which we are having, the interplay between these three deadly things: obesity, type 2 diabetes mellitus, and NASH. I hope my slides are visible to you all. So to set the context, the global prevalence of NAFLD in adult, if you see, it is having a mammoth worldwide prevalence of 25 to 30%. And the prevalence of NASH is actually very well defined, but it is very less well defined. And it is estimated at 1.5 to 6.5%, which is an understatement. And to make things worse, the worldwide prevalence of NAFLD among people with type 2 diabetes is robust 55%. So 1 in 2 person we are coming to our OPD are having a NAFLD. Now, what is the difference between hepatic steatosis, NAFLD, and NASH? Just a brief. Hepatic steatosis is excess fat deposition in liver. NAFLD is a non-alcoholic fatty liver disease, which is a spectrum of fatty liver disease which is related to the metabolic dysfunction the body is having. And NASH is non-alcoholic steatohepatitis, which is due to hepatic inflammation and fibrosis, and it is associated with progressive liver disorder and disease. So NAFLD, it is most common liver disease worldwide. It is very prevalent in modern society due to our eating habits. We are sedentary, we are eating too much of carbs, we are eating too much calories, we are not doing enough for our bodies, and that is the reason of this disease. Now the prevalence continues to rise rapidly with obesity and diabetes, because these two are the soil where it is nurtured, and it is characterized by a fat deposition which is in liver.
So it is progressive in nature. It includes inflammation, liver cell damage, fibrosis, and over 20 to 30 years, it develops into cirrhosis. And it is not related to alcohol consumption. Now, it is closely associated with insulin resistance in liver as well as adipose and muscle tissue. Metabolic syndrome, which we all know, comprises of three of these: impaired fasting glucose or type 2 diabetes mellitus, a hypertriglyceridemia, a low HDL cholesterol, increased waist circumference, and a high blood pressure. So any three of these constitute metabolic syndrome. Now, what are the other common related metabolic disorders? We have seen that in individuals without diabetes, HOMA-IR, a simple test, can be considered as a surrogate for IR. Now, HOMA-IR can be recommended if proper reference value has been established, is a grade A evidence and level 1 recommendation. So it is highly recommended to do a HOMA-IR with proper reference value if we think that the patient is not having diabetes but can be at risk for metabolic syndrome or insulin resistance. But it becomes a limited use for NAFLD diagnosis in patient with metabolic risk factors. Now, during follow-up also, it is under the C grade of evidence. So it might help to identify patient at risk of NASH or fibrosis progression in selected cases. So it is not for that. It is not absolutely meant for that. Now, coming to BMI and waist circumference, they are very positively related to NAFLD, and they are predictors of advanced diseases, particularly in the elderly. Now, the recommendations clearly say that follow-up is mandatory in obesity, which is must. And even follow-up, I would like to say that an obese person should monitor his weight daily. The follow-up should be that strong, and which is the major phenotype and risk condition for NAFLD, driven by IR, and also increases the risk of advanced disease. We have seen many lean individuals also with NAFLD, which display IR and altered body fat distribution. This is very common in India. A lean, thin, fat Indian is very common. So they have NAFLD in spite of being lean and thin. So follow-up is required for them also. Now, irrespective of liver enzymes, diabetes risk, and type 2 diabetes mellitus, it is also associated, they are also associated with severity of NAFLD, progression to NASH, presence of advanced fibrosis, and development of hepatocellular carcinoma. Now, the complication. This is a normal liver. When there is metabolic dysfunction, it develops isolated steatosis. Then there are inflammatory diathesis, which cause inflammation, cell necrosis, which we call as NASH. It leads to fibrosis and it causes cirrhosis. The secondary effects are cardiovascular disorders, and hepatic carcinoma is a direct impact of it. Now, clinical implication of NAFLD and NASH. If we see, it is undiagnosed in most cases because we rarely care for it. It is a bold statement that we never care for our patient with diabetes to detect them for NAFLD. Only 40% of them have elevated liver enzymes, which are usually ignored in OPD. It can progress to cirrhosis and liver failure. It is associated with hepatocellular carcinoma, which is one of the most common cancers, and associated with up to double the risk of developing cardiovascular disorders, which is a major cause of death in people with NASH. Now, the damage to liver from NAFLD is often synergistic with other inducers of liver injury, like viral hepatitis, autoimmune diseases, alcohol, and drugs, and they can compound to the injury which is caused by NAFLD. Now, severity of liver fibrosis stage, it actually predicts mortality. And if you see the all-cause mortality, as the fibrosis stage increases after stage 1, it shows a linear progression. While the liver-related mortality after stage 1 to stage 3 shows a linear progression, then it is a robust rise from stage 3 to stage 4 in the liver-related mortality rate. Now, approaches for currently available treatment, I know, although it will be taken afterwards, but to mention it, weight loss, as Dr. Anuba has told, remains the key, which includes lifestyle, weight loss medications, and bariatric surgery. To reduce CVD risk, we need to treat type 2 diabetes and CV risk factors. We should keep our hyperglycemia in check. Hypertension should be under control, and dyslipidemia should be treated promptly. And there are certain liver-directed treatment, vitamin E and pioglitazone to mention. Now, future opportunities are many, but intervention should be directed at preventing or treating the complications of NASH, which is fibrosis to prevent cirrhosis, tumorigenesis to prevent hepatocellular carcinoma, and metabolic effects should be directed or to treatment to reduce the risk of cardiovascular disorder. And finally, NAFLD and NASH were first described in 1980, just 40 years back. And 40 years later, fatty liver disease has become a global epidemic. and reducing its clinical impact is now a critical component of fight against chronic metabolic diseases, especially obesity. Thank you.
Thank you so much, Dr. Bharat, for an excellent talk. Thank you, Dr. Anubha. And may I please now invite Dr. Amit, Dr. Mahua, Dr. Anubha, and Dr. Bharat to join for the panel. And before we start, I want to say that we have more than 800 registrations and more than 700 logins so far. So excellent discussions going forward, and it's a pleasure being here with all of you. So my first question to Dr. Amit Kumar De, the question is, what is the relationship between obesity and cancer, like we had been hearing, and how obesity might increase the risk of cancer?
Thank you, Dr. Supratik, for that question. And, although we are metabolic physicians dealing mostly with diabetes, obesity, but we often encounter, even in our clinical practice, some one or patients coming in and saying, I got diagnosed with this cancer and that cancer, and I had to be admitted in the hospital for chemo and radio. So I think it exists in the community, in our obese population. What studies are telling us is that there is a risk of more than 13 types of cancers in patients who are, obese, overweight, and especially in the severe obese category, that is in the people with a BMI of more than 40. Out of that, I think most important in females, it is the endometrial cancer, because in the severe obese category, they have a 7 to 8 times risk of getting endometrial cancer. And there is also the risk to the other cancers, namely the ovarian cancers, the breast cancer, the gastric cancers, the thyroid cancers, even multiple myeloma. You have the prostate, the colon cancer. So all these cancers are at a high risk of developing if you are obese. And there are various reasons for that. And, some physiological reasons, especially we see that fat cells produces a lot of estrogen. So that kind of predisposes individuals, especially to get endometrial cancer. And also, we have talked about earlier that the insulin resistance, the hyperinsulinemia, which is created by these fat cells, they have a role in producing more IGF-1, insulin-like growth factor. And that, again, kind of stimulates, various cancers and the prostate cancer. Like Dr. Bharat really rightly mentioned about, the chronic inflammatory conditions like NASH, gallstone diseases, these actually constantly causes DNA damage, and that leads to cell growth, and that predisposes an individual towards cancer. Various reasons, the role of adipokines, the leptin and the adiponectin, they have a role to play in cell growth, and that kind of stimulates towards cancer. So various factors are there which predisposes an individual who are obese towards getting cancer.
Thank you so much, Dr. Amit, for that. The next question to Dr. Mahua. We hear about, before in our medical college days, we used to talk about the Pickwickian syndrome, obesity, hyperventilation syndrome. So how does obesity aggravate the pathophysiology of OSA? What's your take on that?
Thank you, Dr. Supratik, for the question. Actually, obstructive sleep apnea syndrome is a very common kind of a disease nowadays, which actually it is very difficult to get us. It's very difficult to diagnose it, because patients often, they will not say you that I have this problem. Often what happens while history taking, if the partner, if wife or husband, spouse, if they contribute a little bit more, they can, and only that time only we can pick up this problem. But otherwise, it is very difficult to diagnose. Now, in obese person, as there is everywhere fat deposition, and it is true for upper respiratory tract also. There is increased fat deposition in upper respiratory tract, which actually leads to the narrowing of the airways. And also there is reduced muscular activities in that region, which leads to several hypoxic and apneic episodes. And multiple these type of episodes actually can cause the obstructive sleep apnea. Again, we have to actually look for this because this is it is a very important indication for several metabolic syndromes complications. So we definitely have to look for this we need to actually research and do something so that we can diagnose very easily obstructive sleep apnea.
Great inputs, Dr. Mahua. Thank you. Now, the next question to Dr. Anuba. We wanted to understand how big is the problem of obesity when it comes to the female patients? And is obesity considered an important modifiable entity in your clinical practice?
Thank you, Dr. Supratik. And I think it's going great as the program goes on. And Dr. Bharat, it was an excellent, crisp presentation. In my slides, actually, I have covered that the very aspect about the female obesity. For the same reasons, because as such, like Dr. Amit was talking about a hyperestrogenic state. So this hyperestrogenic, hyperinsulinemic, and anovulatory state is responsible for situation of insulin resistance and very many complications of primary infertility in females, the endometrial and the ovarian carcinomas in females. As per se, obesity itself, diabetes, the metabolic complication we are not talking about, it is there. The uterine prolapse, the urinary incontinence, these all are very much associated with female, or I should say the gynecological problems, which we are seeing more and more, which are increasing with obesity. And the studies have shown, like if you are, I think not only we should say the childhood obesity is one of the root cause. The children are, like if you see the COVID era, the kids have stopped playing outside. They were more glued to the TV, and we are having an epidemic of childhood obesity now. So the kids, especially the female kids, they are overweight or obese, they're having early menstrual cycle, they're having irregular menstrual cycle, developing a problem of PCOS, infertility. So this is a definite problem, and the solution is definitely we have to work from that stage, which could be behavioral modification, which could be pharmacological, or something. We'll move on, but that is very essential when we want to talk about, because now women who were protected because of this estrogen are losing their beneficial effects of estrogen because of obviously are changing in lifestyle. So definitely we need to work more harder because the complication will be more severe.
Thank you so much, Dr. Anuba. Thanks a lot. So Dr. Bharat needs to leave. He has another talk, so we'll just keep this very brief. So we know that majority of the patients who walk into your clinic are in denial. So how have you found that in your clinical practice? What is the acceptance rate that obesity is a problem among your patients?
That's a wonderful question, Supratik. First of all, obesity is never accepted. It is always denied. And everyone will agree to it. No one accepts that they are overweight, barring few people who are actually concerned. Otherwise, they think that hum to khate pite ghar ke hain. This is very common with us, and we are like that. My mother was like that. My father was like that, and everyone in the family like that. Because there is no one who runs in the family, so obesity runs in the family. Now, the biggest problem is to make them aware about their BMIs and how it can impact them. This is a big problem. And we all who are sitting over here, and this is my sincere request to all of you, we need to devise something, some methodology, some leaflets, by which we can educate people just by putting it in our clinic. By the way of that, we can sensitize people about obesity, because now we have a mission in our hand with OMOS, and we can do it. So if we can create that sort of stimulation which is required to make it considered as a disease, because first of all, people don't consider obesity as a disease, while it is a mother of all the diseases, as Dr. Anuba has told. So everyone will agree to it that there is a huge need of sensitization. There is a huge denial. It is not with me, it is almost with all of you who are present over here. And people never accept that they need to take medication for obesity. Hum bhag ke kar lenge, hum chal ke kar lenge, and there are various ways that they tell. But actually, it is a disease like any other disorder. We need to put the brakes on the specific points which are required. And sometimes we are focusing only on the diet and on the exercise, but the problem is something else, and we need to tackle it. So actually, sometimes it is related to disease also. Many patients comes to me with Cushing's. and they are obese. They have stria and all those things, and they are not diagnosed. While a simple test can diagnose it, and this is actually we need to do, and we need to do more on this.
Super. Thank you so much, Dr. Bharat, for your inputs, and it's a pleasure having you on board. And
thank you, everyone.
We'll keep this mission alive. That's the purpose. So the next question to Dr. Amit. We have heard that gaining weight or obesity obviously increases the risk of. Yes, but we are just asking one more question before we do the felicitation. Not so easy. So we will come back. Just one of a couple of more. Great. Thank you. Thank you so much.
That clap was for Bharat Bhai, actually.
So we won't keep you for long. Just a quick question to Dr. Amit and Dr. Mawa before we can conclude. So we were saying that we have learned that, obesity increases the risk of cancer, but is there any evidence that if you lose weight, that reduces the risk of cancer?
Yeah, that is a very interesting question. There is, they say that, about 3% of 3 to 5% of people, of men who are obese have a risk of developing cancer, and about the risk is just the double in women. So about 9 to 10% of women who are obese will have a risk of developing cancer. Now, does losing weight reduce the risk of cancer? Well, that is a question that needs to be sort of studied more in details, but there are some evidences from the case control and the cohort studies, mostly the observational studies, that does go on to say that yes, if you're losing weight, then it reduces your risk of cancer, especially the cancers like endometrial cancers and the ovarian and the breast cancer. But there are also some strong evidences which are coming that post-bariatric surgery, the risk of cancers are comparatively much lesser in the cohort group at earlier higher risk of getting cancers in their particular group. So the evidence is not very strong. We know that obesity is strongly associated with cancer, but whether losing weight reduces the risk of cancer, because there are various other factors also which are associated in cancer and its pathophysiology. So being an associated factor always, but whether it is solely responsible for reducing the risk of cancer, that is not very clear, but there are some French evidences that we have at it.
Super. So the last question is for both Dr. Anuba as well as Dr. Mahua, and we'll have both of your inputs on this. So how does weight management benefit patients with conditions like PCOS, something that we very commonly come across, and many of our gynecologist colleagues treat them before we get to see them, infertility, and also possibly urinary incontinence?
Yeah, ma'am, you first.
Okay. Thank you, Moa. Actually, what we are talking about, like PCOS, is a part of insulin resistance. Definitely, once we motivate the patient for weight loss, it could be the behavioral therapy, which is more the non-pharmacological, holds the clue. Definitely, the gynecologist colleague would be only interested in regularizing the menstrual cycle, but the root problem lies with the weight. Though they can be lean obese patient, I won't say they all will be having morbid obesity, but definitely weight loss, either you use metformin or the non-pharmacological measure, will definitely improve the anovulatory phase of the cycle, the other parameters of the insulin resistance, and the problem of PCOS can be tackled because they have basic problem of menstrual irregularity, of infertility. So both the problems, the root cause of treatment of obesity or addressing the issue, I will not say treat, I'll say first address the issue of weight loss, then definitely you can have medication for the symptomatic treatment. Mahua, you can put some input on that.
I fully support ma'am, Anuba ma'am, and just to add with you, ma'am, actually, I feel obesity management actually should start, the beginning should be there from very own home, from the kitchen itself. if a person's mom actually she can realize that her children are getting little bit obese, from kitchen itself she can actually do. And also some schools activities in the syllabus, this is also very much needed, like other sex educations and other education. Health education is also very much needed in the school service. And also that's what ma'am told, that we should accept that we are obese and our children are getting obese. So we should accept that. All moms should accept that. Okay, because moms are very much like khilao as
obsessed with eating.
Eating,
We feel
yes.
खाना खिला के ही सब कुछ होता है.
सब brain हो जाएगा खाना खिला के.
You know, the right time, right food, right amount. That is the most neglected thing.
Yes.
And I think her point is very well taken. Health education about the health at the school level, at the kitchen level is very important.
Yes. Yes.
And the females may hold a clue for us.
Yes.
That if we educate them, if we impart them, they are responsible for the health of the whole family.
Yes, true. Very true.
Very well said, Mawa.
Thank you, ma'am.
Wonderful. Thank you so much for all these valuable inputs. And now can we have one more time the felicitation for our faculty. Neelamji, one more time, please.
Neelamji is also multitasking.
I know.
The conferences.
Neelam is having a very difficult time.
Selflessly, we would clap for such nice celebrations.
So
thank you.
So mementos will be reaching you very shortly to your postal addresses. So thank you again for an excellent session.
Thank you all for this wonderful session, ma'am. Thank you, Dr. Bharat Sabu. Thank you, Supratik. Thank you, Amit. And thank you all those who have joined here.
So thank you so much, all of you. Thanks a lot. Take care. We move to our third phase. We're moving gears. So first, second, now we are on to the third gear. And the disclosure is this is a Novo supported session. So can we have the slides of the moderators, please? So our first moderator is Dr. Rajesh Deshmane. He's diploma diabetes and FCPS medicine consultant and a diabetologist and metabolic physician from Kolhapur with 17 years of experience in exclusive clinical practice in diabetology. He's got 10 years of experience as principal investigator on numerous phase 3 drug trials, medical care of diabetic patients being treated at only center in Western Maharashtra, and clinical drug trials as per the ICH, GCP and regulatory guidelines and innovative research. More importantly, he's a very dear friend of mine and an excellent speaker and organizer. So with this, our second moderator, slide please. Again, a very, very dear friend of mine, Dr. Abhishek Srivastava, is an MD, PGD endocrinology from Royal College of Physicians, DMSc endocrinology from Cardiff University, endocrine and diabetes physician, and he's the director of R&R Hormone Clinic, Jabalpur, and community board member of American Association of Clinical Endocrinologists. And he was one of the award winners last year at the ACE conference. Recipient of the Eugene T. Davidson Public Service Award 22. This is what we were talking about at ACE. President of Asia Pacific Society of Endocrine Research, editorial board member of Journal of Endocrinology and Metabolism, and he's an editorial board member of the MST Research. Received the Hetkeva Rising Star Award from the IMA Centenary Conference, received Diabetes India Award 2029, and received Research Excellence Award in 2020 for his study on hypergonadism. Now may I request Dr. Rajesh and Dr. Abhishek to please introduce our speakers for tonight.
Yeah, Dr. Rajesh, please go ahead.
Yeah.
Hi, hello everyone, and thank you, Supratik, for this nice initiative. So, it's my pleasure to introduce my good friend, that Dr. Sonali Bhojne. She did MBBS and then postgraduate diploma in diabetology from United Kingdom. She is practicing as a consultant diabetology in Pune. She also did her postgraduate diploma in clinical endocrinology and diabetes from Royal College of Physicians, UK. She also got fellowship in diabetology from Royal Liverpool Academy, United Kingdom. She is the director of Nectar Diabetes Center, Pune. She is winner of Diabetes India Award 2021. She also recently awarded as a Maharashtra Idol Awards, Pune, in 2022. So over to Dr. Sonali for her nice deliberation.
Thank you, Dr. Rajesh, for those kind words. At the outset, I would like to congratulate Dr. Supratik and the whole of the MOS family for the official inauguration here. We know the efforts taken by Dr. Supratik for the last whole 1 year, I can say, and putting us all together for this wonderful meeting. So without much of a delay, I would are my slides visible?
Yes.
Kindly put it on the full screen mode.
Full screen.
Yeah, good to go.
Yes.
So we have gone through the etiology, we have gone through the various causes, the pathophysiology, we have gone through the cardiovascular effects of obesity, and now it's a turn for weight management. So I'll be discussing weight management in adults, specifically the guidelines, which are the Canadian guidelines, which have been accepted all over the world, and how do we translate those guidelines to clinical practice. So in my short presentation, I would be discussing about the various options available for obesity management, how guidelines have been evolved, and how they guide us to integrate the available treatment options, and how to translate these guidelines to clinical practice through a clinical case. So this all we know that we are treating obesity as per the BMI and the BMI cutoff, and which has been recently changed by the Canadian guidelines. So we follow the stepped approach for the effective obesity management, and as the BMI increases, we move our management protocols from dietary regimens and the dietary changes from physical activity promotions to pharmacotherapy to sometimes the surgery. So this is a comprehensive lifestyle approach which is being currently recommended, and the very important fact that the behavioral therapy is being added here. So we have been doing physical activity promotions, we have been advising our patients for the powerful exercise regimens, we have been advising the healthy eating patterns through our dietary approach with the help of a dietitian. But you and me know very well that how successful that act is, and probably we have heard about the various causes of obesity. It is not just eating pattern, or it is not just the lack of physical activity, but it is the behavior, it is the brain which is being connected, and that's how we have to really concentrate on the behavioral therapy, which will include the self-monitoring, the goal setting, and the substitutional behaviors. So in spite of all this, sometimes there is a less of a success, and then we have to move for pharmacotherapy. And when should we move to pharmacotherapy for obesity management? It is like when we have tried the lifestyle changes, but we cannot reach a healthy weight. Or there is a weight cycling, as we call it nowadays, that there is a regain of weight after losing it, or there is a morbid obesity, which we used to call earlier, and it used to give us a cutoff of 30 grams per meter square. So yes, pharmacotherapy is there, which is available, and we have to consider the pharmacotherapy looking at the various causes which have been very well explained by Dr. Parikh, and that suggests that only the dietary modification and the exercise regimens are not helpful, and probably that is how the pharmacotherapy can be helpful. So coming to the pharmacological options, obviously we won't go into the details, but yes, I would like to discuss about liraglutide and the orlistat and the semaglutide, which has been in vogue nowadays. And mind you, liraglutide with a dose of 3 mg is being approved for the weight loss in a non-diabetic population. So these are the options, and if you see the various effects of this pharmacological options, yes, they do, they are helpful, but again, I would stress upon it is at the background of dietary modification and the exercise regimens. These are the proposed mechanism of action for the current anti-obesity medications, and by now I think everybody knows about the etiology, how there are complex mechanisms which are involved centrally in the brain, and how there is a gut-brain axis which is being involved, and how can we utilize these anti-obesity medications for our patients. Yes, surgery is an option for selected patients with obesity, and we have seen the results as such. There are obesity surgeons who are working on their toes and they're showing the effects, but again, there is a problem of weight cycling, I would say. They lose the weight and again they regain the weight. So there is something which we have to additionally do when we are addressing obesity as a whole. So there comes the obesity treatment guidelines. Yes, one size doesn't fit all. And why? Because the patients with obesity, they are diverse. There is a difference in the age, sex, genetics, complications, concomitant medications, and various factors like socioeconomic status, the culture, the festivals, the personal preferences, everything putting together. The patients with obesity, we can call, they are diverse, and that's how we have to have the individualized approach for the obesity management. Also, not just the patient itself, they are they vary in their phenotypes and their in their pathophysiological etiology, but even there is a heterogeneity of treatment effects. So there is a great variation in weight loss efficacy response, which we see. And for that matter, even by the gender, we see that there is a different treatment effect, which we usually offer them. And there are some patients who may be susceptible to the adverse effects of the treatment also. So all the bariatric surgeries which have been done, probably they don't do good to all in terms of vitamin deficiencies, in terms of their satiety levels, in terms of their pleasure of eating. And we have that vast clinical experience with our patients going through all these obesity surgeries. And there's some treatments, they may have weight loss independent health benefits, and thus some patients may achieve the additional health benefits. So this is something which is very, very important point here, as the treatment may not affect only the weight loss, it may not affect only the weight, but there are other benefits, the metabolic benefits which we can achieve. And that's how the current guidelines, they have incorporated these health benefits and not just the weight loss. So the guidelines describe the obesity treatment pathway as to, first is you have to diagnose the obesity in terms of BMI, and we have to stage. So a couple of minutes here to discuss about the staging, because till now we have been classifying obesity as per the BMI, and probably the BMI is something which is not enough, as Dr. Anuba has already discussed. But BMI, along with the waist circumference, as it indicates the cardiovascular risk, probably combining together gives a better outcome in terms of treatment options to choose for, because we, being the Indian population, we have normal BMI obese patients, as we see in our clinics day in and out. And that's why, along with the BMI, probably the staging and Edmonton staging is something which we have to consider in our treatment protocol for effectively managing diabetes, not just directing at the weight loss only, but also directing towards the health, achievement of health and prevention of complications as a whole, which we all know by now that there are more than 200 diseases which are being associated with obesity, as discussed by Dr. Arvinda. Yes, there are three-tier treatment pathway, and we know that diet, exercise remains the baseline. Then there is a pharmacotherapy and the surgical options which are being available. And there are different guidelines, but all these different guidelines, they are BMI centric, and probably we need something more as it's been done by Canadian guidelines. And if you see all the guidelines which have been evolved through through 2014 towards 2020, the BMI centric guidelines have been changed to complication centric, which is the right thing to do at this point of time. So overview of Canadian obesity treatment guidelines, and which has been well accepted by the whole world by now. And it is like, it starts with, we have to consider the BMI, and then we have to consider the comorbidities, likewise in diabetes, pre-diabetes, hypertension, obstetric sleep apnea, PCOS status, and we have to consider the stopping or changing medicines associated with the weight gain, if possible. And again, the craving, the depression, so psychosocial aspects needs to be addressed. And along with that, we have to keep on, there are 5 stages which have been suggested and recommended by Canadian guidelines. And they say that first you have to evaluate the patient for the obesity. You have to then go for the physical examination, then for the laboratory workup, and then you have to consider the patient treatment option as to whether this patient needs more than dietary and the exercise modification in terms of medications or in terms of surgical options. But the story doesn't end here. They also recommend to sort of a target for the continued weight loss. So it is not just the weight loss, you do the weight loss and forget about it. It is like the maintenance of the weight loss is something which has also been suggested by the Canadian guidelines. So obesity guidelines, to summarize, we have to define as per the obesity and as per the complications. And yes, management includes the lifestyle management programs, the pharmacotherapy, and the pediatric surgery. For pharmacotherapy, there are various obesity treatments which are available, and the GLP-1 receptor agonist, which will be discussed very soon in the next presentation. So moving from guidelines to clinical practice, we would go through a case. This is a typical garden variety case which we see in our clinical practice. She is 38-year-old, whose BMI is 29.5, pre-diabetic, A1C 6.2, hypothyroid, normal TSH, PCOS, currently taking levothyroxine, and she has done many prior dietary efforts to reduce, and probably she's a case of weight cycling, which we call it nowadays. And then she regains and she loses weight, she again regains. So mainly the central obesity is her problem. She's being frustrated for not being able to lose weight and wonders if the thyroid is the cause. And usually it is seen that thyroid is being given the blame if the patient has the pre-diabetes, diabetes, and the thyroid together. There is a family history of diabetes and heart disease. So we would go through these 4 questions. That is, does she have obesity? Why do you think she needs treatment? And how severe is her obesity? And what are the treatment options? Coming to, does she has obesity? If you say obesity is called only when the BMI is crossed 30, then it is wrong. But then this obesity, now what we call obesity, which is a complex chronic disease, which is abnormal excess body fat, which impairs health, and there are increased risk of long-term medical complications. So if you remember the case, you would agree with me that she has pre-diabetes, she has a family history, so she's at a higher risk for the long-term medical complications and a reduced lifestyle. So yes, even though she doesn't fit into that BMI bracket of more than 30, she can be called as obese. So why do you think she needs treatment? Again, as Dr. Ruby has excellently explained about the weight loss percentage and the benefits which she gets it, probably 5 to 10% bracket fits for her. And yes, that will give her the prevention of type 2 diabetes and also the successful treatment of PCOS. How severe is her obesity? So this is the Edmonton obesity staging system, which I had mentioned earlier. So this considers the medical metabolic position of a patient along with the mental and the functional disability. So this is something which we all should incorporate in our clinical practice, and we should start treating obesity as obesity class as per the BMI with obesity stage. So there can be various permutations and combinations, and there can be like obesity class 2 but stage 2, or maybe obesity class 3 but stage 1, or various complications. And that's how we should be we should have the targets for an individual treatment to address the obesity for that particular for that individual patient. So what are the treatment available? As I said, psychological and behavioral intervention is something which is very, very important. And then we have to have those, we have to implement the multi-component behavioral modification, and we have to manage the sleep, time, stress, everything we know. Cognitive behavioral therapy remains the cornerstone for the obesity surgery, besides the pharmacological treatment options available and the bariatric surgery which is there. So yes, we won't go into the details of this, but as per the recent Canadian obesity guidelines, what should be the treatment approach for our patients? So metabolic syndrome with prediabetes, PCOS, elevated weight, and a family history. So she's at a higher risk, and that's why she should be treated irrespective of her BMI below 30. Ethnic background, yes, and even without lifestyle modification, nothing is possible. Along with that, the pharmacotherapy for weight management can be addressed. And as I told, that it is not just the weight loss, the story doesn't end here, but it is the continuous follow-up which has been required, continuous the motivation which is required to adjust the treatment as noted, and to prevent that weight cycling, which is a prime problem with the weight loss regimens which we are following right now. So to summarize, obesity guidelines have evolved to focus more on complications rather than BMI, and it is a high time that we should incorporate these guidelines along with the Edmonton staging to effectively address the obesity. Behavioral intervention is something which is very, very important, and pharmacological therapy or pharmacological agents and drugs, they are there at our help. But yes, behavioral therapy remains the cornerstone for the obesity management after all. So with this, I stop here, and I thank you all for the patient hearing.
Thank you, Dr. Sonali, for an excellent session. Now, may I please request Dr. Abhishek to please introduce our next speaker.
Thank you, Dr. Sonali, for such a nice deliberation. And our next speaker is Dr. Meenal Mohit. She is MBBS, MD, FD, FPA, FRC. Yeah, please.
We'll keep it brief, Abhishek. Just the name is enough.
Please, sure. Just 2-3 lines. Major achievements: mentor of Team India, won Oscar Cup in ACB 2021, pioneer of Cloud Clinic Venture MS COVID-19, editor of MediBeats, and founder member of EMOS, and founder of Women Practitioners Forum. That's most important. Thanks a lot, Dr. Meenal, and please continue your sessions.
Thank you, Dr. Abhishek. Thank you so much. And first of all, yes, a big congratulations to all of us, and especially to Supratik. So this was his brainchild, and it was his brainchild, but he kept eating my brain. That's a different story. So I remember the first time when he was asking to give it a name. The association should be given some name, and we were just breaking our heads what name should come up. And then, of course, today we are actually visualizing his dream come true. It was his brainchild, his passion to have obesity forum and obesity clinicians. And so we all are here to congratulate him, to support him, to be with him on this journey to fight obesity. So with that, thank you, Abhishek. Thank you everyone for putting up till this last lecture probably. So if I share my slides, okay. First of all, before I talk anything about the slides and the presentation, let us make it very clear that obesity is a polygenic disease. It is a close interaction of genetics along with environmental factors. So when Sonali was talking about the questions we must answer, probably we must add one more question, Sonali, that what is our target weight for this particular individual patient? So we have to have a realistic and an acceptable practical target for all our patients. You cannot have just one target, or we just cannot think of we need to make everybody just perfectly at the ideal body weight. So how much weight loss for this particular patient is required or recommended as per to avoid the metabolic complications? Because as you rightly said, the latest guidelines are that the patient should be metabolically fit. So to be metabolically fit, maybe we also need to add one more question to your list of 4 questions, that how much weight loss for this particular patient would make the patient metabolically and clinically fit. Now coming to the potentials of GLP-1 RA for the treatment of obesity and its complications. So again, I will tell you, nothing works. This is my disclaimer that we have no conflict of interest. So coming to the pharmacotherapy. First of all, obesity, yes. So we have been discussing obesity from past almost 2 hours now, and we all have come to a consensus that it's a progressive disease. So both the words are important, that it is a disease, yes. It is progressive, yes. So the center, as Dr. Parikh and others have also mentioned, that it is not a very simple game of energy intake and energy expenditure. We have a central focus somewhere in the brain, the hypothalamus, which is playing its role in controlling our appetite and in also controlling the energy or the calories that we burn. So there's a complex interaction between the genes and the environment. It's a global pandemic. Yes, that is very evident. That is why we all are here today discussing obesity, and the worldwide, the globe, across the globe, obesity is being discussed. As Anubha rightly said, it is almost second diabetes now. Now, the complications arising from obesity can be very many, and most of them are focused around the metabolic complications. No, they are beyond metabolic complications. Even psychologically, even your self-esteem, your ego, your attitude, everything is designed by the body shape. So obesity is much, much more than what we think and we can discuss. Weight loss, achieving weight loss is probably not very difficult, but maintaining that weight loss is a bigger challenge. And not allowing the rebound, as was also mentioned by one of my colleague speakers, that there is always a rebound in weight. So diet alone will not help. Physical activity you can put up to certain level. After that, there are limitations. Behavioral modifications, yes, they are important. And of course, we are always there as doctors for our patients and for ourselves to help them lose weight with some medicines. And the medicines are also having a capping effect. They can also make your patient lose weight to some level. Then after that, we also have surgeries available, and the bariatric surgery, or even the latest, the balloon therapy that we all have heard recently. They are also playing a big game in making the patients lose weight. So that is a background of obesity and the pharmacotherapy. Pharmacotherapy is not new in obesity. We began way back with orlistat. Even fentiramin was used. Fentiramin is still used in some parts of the globe. Then fentiramin, topiramate, and the combination of fentiramin, topiramate, naltrexone, bupropion. Even we remember the molecule rimonabant, which was withdrawn because of the suicidal effects, but it had very good weight loss capability and efficacy. And surpassing all of them, we have something called the GLP-1 RA. So the GLP-1 RA came as a very interesting and a very happy change in our prescriptions, because GLP-1 RA could make our patients lose significant weight. But the challenge was that they were injectables. So that injectable challenge has also now been overcome by the introduction of semaglutide in the market, which is oral, but the efficacy and approval of sema as a weight loss molecule, we are still awaiting that. So all these molecules, how do they work? Out of them, orlistat, that is one molecule which prevents the fat absorption. So this molecule is taken immediately after a fatty food or after a fatty meal, and it works by not allowing the calories or the fats to get absorbed. So they work by energy wastage. Remaining most of the molecules, they work by cutting down your appetite. So they do not allow the patient to eat food. They do not allow the patient to consume more calories. Out of this, if we focus on the GLP-1RA, which is one of the best of the molecules so far, we find that liraglutide on other GLP-1RA, they work both at the central level, that is a hypothalamic level, by cutting down your appetite, cutting down your food cravings, and also they work at your GI level by slowing the gastric emptying and making the patient feel that he is full for quite long. So that is how this molecule is different, working at the central as well as the peripheral level, and is having a good result in terms of weight loss. So now if we look at the interventions for the weight loss, you will find that yes, right from since long, when we were trying with the lifestyle modification, the look ahead trial or the direct trial, the weight loss was somewhere around 3 to 10%. Most of these molecules have also given us the similar results, that including the GLP-1RA, that the weight loss is somewhere averagely. We are not talking of the exceptional cases. We all have our stories, I know, but we are not talking of the exceptional cases. On the routine basis, we find that the average weight loss with the medicines is somewhere around 10% of the existing body weight. So the best weight loss that we are talking, that we need when we talk of BMIs 35, 40 or 30 with comorbidities, we do not need just a 10% body weight loss. Of course, metabolically it will help, but for the patient satisfaction, to avoid psychological depression, we need a weight loss which is almost around 25 to 30% of the existing weight, and that is only possible with surgeries. But after losing that weight, even by surgery, you need medicines to maintain that weight loss. So the ball again comes back to the physician's court. Now this is the gap. Whatever you can achieve by diet, exercise, intensive lifestyle modification, or even drug therapy is just some 10%. But with surgeries, it can be almost up to 40%. So this is the gap. And this treatment gap is difficult to patch up. But yes, after this, again, you need to help your patient maintaining that weight loss. Coming to the GLP-1RAs, a little journey of the GLP-1RAs. GLP-1RAs, initially we found it was launched somewhere way back in 2009 and 10. The Byetta, that is exenatide, they were all exendin-based GLP-1RAs, and they were given twice a day, that is BD dosing. Then we had lixisenatide, but then we came to human GLP-1RAs, and we had liraglutide with us. Then we had once a week therapy, that is dulaglutide. And of course, now we have the oral sema with us, which is a revolution, a peptide in a pill, which is a big game. So the studies with liraglutide and the weight loss, which was documented across the phase 3 trials, the doses recommended as weight loss molecule were 3 milligrams, and the maximum weight loss that was reported in the various trials was somewhere around 8%, 6%, or 6.2%. Now we have sema, and this further talk will be focused around sema, but the semaglutide, we are not talking about the oral sema which is available in India. Most of the trials about weight loss and semaglutide have been done with injectable semaglutide, which is not yet available with us, but the data that I'm sharing is are from the trials that have been done with injectable semaglutide for weight loss management. And the recommended doses are 2.4 milligrams of semaglutide has to be injected, and this is a once a week therapy. So the GLP-1 based compounds, they are further more in pipeline, and one of them, that is a twin cretin, that is tirzepatide, we are soon going to have with us. So the semaglutide, how does it work? Semaglutide, it's another GLP-1 analog, GLP-1RA, with 94% homology to the human GLP-1 human GLP-1. As a result, the semaglutide acts at the hypothalamic level. There are some modifications, and to make it orally absorbable, a snack has been added to it, which prevents the damage in the stomach, and it creates an artificial acid milieu inside to allow the molecule to get absorbed. But talking about the injectable semaglutide, this molecule has been genetically engineered by substitution of certain amino acids, and it works at the hypothalamic level to cut down your appetite, reduce appetite, and at the peripheral level, it keeps your stomach full by delaying the gastric emptying. So not only it helps in cutting down your energy intake, but besides this, it also has some other metabolic effects, and the leader has proven in the leader trial the benefits of GLP-1RA as a cardioprotective and a cardio beneficial molecule. So we are expecting same results with the semaglutide, though we have the sustained trial with the injectable semaglutide, which is also approving its metabolic role beyond the weight loss molecule, and it is its protective role in the cardiovascular diseases. So these were the radiological studies which have shown that how selectively the molecule is taken up by the hypothalamus and the hindbrain. So this is where the molecule is labeled by the nuclear medicine department. It is labeled and the molecule is administered to the patients, and it is selectively taken up by the hypothalamus, central nucleus of the amygdala, and certain other areas of the brain which control appetite and which control your calorie records. Now, the semaglutide phase 3 program with 2.4 milligram, which is the dose which is recommended as the weight loss molecule. These are the step trials, and all the step trials, right from step 1 to the step 10 trials, are focused around the weight loss plan or the weight loss benefit of semaglutide, which is the injectable semaglutide this time. So the various studies have shown that across the step program, when you go on escalating the dose, you begin with 0.25 and go on escalating the dose and reach the maximum tolerated dose to 2.4 milligram, you will find that the weight loss was significant, and the trial programs have been conducted more than a year across, almost around 68 weeks. Then there was another which was 104 weeks. It was based on China population, and there were a lot of studies from step 1 to step 10. Even they had included patients with heart failure with preserved ejection fraction, patients with type 2 diabetes. Then a select trial, which was specifically focused on the CV outcome trial. So there have been a lot of studies with the semaglutide injectable, and almost all the step data I will share here with you has shown that there was a significant weight loss, almost around 20 kgs. So almost 20 kg weight loss has been reported with a semaglutide of 2.4 milligrams over a period of 1 year and so. Putting it the same data, putting it across in another way, you will find that more than 5% weight loss was reported in almost 80 to 90% of the patients who were on semaglutide for almost a year. And more than 20% weight loss was reported in almost 30 to 35% of the patients across the studies who were taking semaglutide injectable 2.4 milligrams. And this weight loss benefit, right from the beginning, right from the initiation, it was continued throughout the study and even 7 weeks beyond the study, because it's a long-acting molecule. So the benefit of weight loss was seen and witnessed even when the drug was withdrawn. Beyond weight loss, yes, it's a GLP-1RA, so it will have its effect on glucose metabolism. It will help in HbA1c reduction, and this HbA1c reduction is beyond what we see because of weight loss. And also, it will have its CV benefits. So it is a molecule which has mortality benefits because it is having a cardioprotective role. Now, this is another evident fact that fat has very less weight. So fat reduction begins much earlier, and inch loss or shape definition change in the shape definition occurs much earlier. Then you can document weight loss because fat has less weight, is lighter. So by the time you can document weight loss, you can already appreciate the shape change and the fat loss or the inch loss. So the similar data is presented here, that there was a significant reduction in waist circumference. So the waist hip ratio also changed. And the change in the waist circumference with semaglutide was almost around 15 centimeters. So this was a documented reduction in the step 3 trial, in the step 3 and the step 5 trial. Now the fat loss as per the DEXA scan. Again, almost a similar data. You will find that right from this initiation phase, there was almost 54% fat, lean mass and 44% fat. Now the same patient on semaglutide 2.4 milligram, there is an increase in the lean mass by 3% and a fat percentage loss by 5%. So there is almost a 3 to 5% loss in the fat mass and 3 to 5% gain in the lean muscle mass. Abdominal visceral fat, as Sonali was mentioning, we are the thin fat Indians. So we have a lot of visceral fat, and that visceral fat is also affected. So this molecule can also be recommended for not so obese people, and those not so obese people who are still metabolically fat because of the visceral fat are also benefited by semaglutide when the sema is introduced in 2.4 milligrams subcut. And the visceral fat reduction has been documented as almost 65%, and here almost 40%. Improvement in the cardiovascular and the metabolic risk factors, again, from change from baseline has almost around 5 to 6% in reduction in systolic blood pressure, reduction in the diastolic blood pressure. Also the cardiac marker, the cardiac risk markers, that is the CRP, there is change in the hsCRP by 50%. There is reduction in the triglycerides. And if you remember, triglycerides are directly translated into hyperglycemia. So reduction in triglycerides will also help in controlling blood glucose and reduction in HbA1c. Now the SELECT trial, which was specifically CVOT trial for the semaglutide, and here sema compared to placebo after a run-in period and with a same primary endpoints and secondary endpoint of CV benefits, that is the 3-point MACE and the 4-point MACE, that is the reduction in non-fatal MI, non-fatal stroke, and the CV mortality reduction. You will find that semaglutide has proven its efficacy. There is a significant reduction of CV mortality and CV for the 3-point MACE benefits have been shown. Now the side effect profile. Side effect profile, as again shared by all the GLP-1 RAs, there is nausea, vomiting, diarrhea, loose motion, constipation also reported by some group of patients. But studies say that patients tolerate all of them. Clinically, we are seeing that in India, we have oral sema. So clinically, we are seeing that most of the patients are tolerating up to 7 milligrams. But once you shift them to 14 milligrams, then there are few dropouts. So SEMA 2.4 for weight management, GLP-1 based compound, there are more in the pipeline. The journey way back, right from 1980 to 2022, we have oral SEMA with us now. We are looking forward to tirzepatide, which might be there by the end of this year or maybe the next year. Then we have future molecules also, where we are looking at the combination of even the amylin analogs to be in the market in combination with GLP-1 RA. So this is SURPASS trial, the SURPASS trial by 1, 3, and 5. Here we are having tirzepatide this time, that is a twin cretin, the GIP and the GLP-1, 5 milligram, 10 milligram, and 15 milligram. Of course, we have seen significant weight reduction in all the three trials with tirzepatide. Another molecule in combination, that is the amylin analog, that is the cagrilinotide along with semaglutide. The Novo has already done its phase 1 trial and the results are quite promising. We have a lot of more molecules in pipeline. They're all in phase 1, phase 2, phase 3, and phase 3 trial, sorry. In India, we are looking forward for the approval of SEMA and LIRA as anti-obesity molecules. So just to summarize this evening and this lecture, that pharmacotherapies will be required besides diet and exercise And we are ready for that. We are very much there to help our patients with pharmacotherapies, beginning right from GLP-1RA, which are quite promising. The only request to the pharma companies, please make them a little more economical so all my patients can afford them. So GLP-1RA has shown clinically good results, robust results as molecules to lose weight and as molecules to maintain that weight lost by whatever methods. Semaglutide, which is the latest baby in the basket, we have only the oral available with us and has shown almost 20% weight reduction in the step trials as injectable. So maybe soon we can have that injectable sema available. And of course, the tirzepatide is there in the pipeline, carglantide is in the pipeline, and a lot more. So with that, I thank you all once again for being here this evening. Over back to the organizers. Of course, I know Supratik is very anxious to jump and
Thank you so much, Dr. Minal, for a wonderful presentation. Thank you, Dr. Sonali, for a wonderful presentation. Just wanted to mention, like amazing things are happening, and this cagrilintide, along with once weekly semaglutide, this combination has having the potential of 30% weight reduction, which is matching the bariatric surgery. So we're looking into future where probably bariatric surgery is going to be a thing of the past. So a lot of exciting things in the pipeline at the moment. So may I now ask Dr. Abhishek, Dr. Rajesh, Dr. Minal, and Dr. Sonali to join the panel, please. And the first question, of course, will go to Dr. Rajesh, and it's two questions in one. So one is, we already sort of addressed this, but again, to reiterate that many people do consider obesity still to be a mere lifestyle disorder and not a serious chronic disease. So how do you usually address this in your clinical practice? This is part one of the question. And part two is, do you think there is a role of a nutritionist or a counselor when it comes to the obesity care? And how do you utilize that in your clinical practice?
It's very true that most of our patients, actually, they don't feel obesity as a disease. But actually, in our day-to-day OPD, being a diabetologist, most already patients have the known side effect of obesity, that is either diabetes, along with that hypertension, along with that dyslipidemia, coronary artery disease. So for us, it's very easy. But when we treat their relatives for obesity, because anyway their relatives will, because of its genetic issue, there are chances of they becoming diabetic or cardiovascular, for future chances of any cardiovascular disease. It comes to when, and for any counseling, then I think right now what I think Dr. Rakesh or Dr. Dhruvi already told us, that after this COVID era, many of our obese patients die because of COVID problem, whereas lean patient, thin patient, they survived a lot. So automatically it's now there is awareness regarding obesity in the society. Also, I think one of our other initiative, as we are also United Diabetic Forum member, so we are running a campaign that is ROAD, Recognize Obesity as Disease. That campaign is also going on, and I think all these things are continuously when we tell our patient that this can be the complication, then it's very easy. And as you rightly said, the role of dietitian. So I'm very much fortunate that my wife is a registered dietitian. She's doing PhD in nutrition. So for me, it's very easy, and that's why whenever a patient comes with obesity in my clinic, it's very easy for me to ask my wife to do something for him. And if we look at the role of dietitian in the management of obesity, particularly it's obesity is always we look at obesity as integrated care, along with a physician or physician. There should be a dietitian, or there should be a basic what we call as a counseling person who will always regularly should take care of most of our patient. And for that, if you look at all the data, the first choice is dietitian. So most of Doctors also advise our patient, obese patient, to go visit a dietitian, consult a dietitian. And people with obesity also feel they should consult a dietitian before a doctor for treatment. So that is very good, and for most of us. And if you look at the impact of diet as well as healthy eating, it's almost as good as a medicine what doctor prescribe. So if we combine diet and medicine along with exercise, then the effect will be exceptionally good. So dietitian are integral part of obesity clinic, and it's always tell that if we dietitian basic role is no doubt just nutrition, but health and as well as health counseling. But apart from that, food planning, preparation, and counseling and behavioral changes. So always the counsel patient need counseling, and for counseling, dietitian plays a very important role. So I think this is very important. They most of the time they develop rapport with patient. They all take a recall every visit. So that plays a very important role in most of our diet clinic.
Thank you so much, Dr. Rajesh. Next question to Dr. Abhishek. So what about the psychological evaluation? Do you think it should be mandatory for all obese patients who comes to our clinic? And do you think it aids in our decision making in sort of creating a support system to understand this psyche and regarding the obesity management and going forward?
Yeah, certainly. See, what I actually think is behavioral therapy should be the first intervention where a physician should actually go ahead. All the nutritionists, dietitians, physicians, all these factors. One term actually, a very interesting term, that is hypothalamic pituitary anxiety. All the obese patients, not even obese, even a patient, a metabolic disease patient, do suffer from hypothalamic pituitary anxiety. So whenever, if you are prescribing, or even if you are saying to like prepare some dietary restrictions for that patient, be it obese, be it a hypertensive or a diabetic, first of all, he will not think about the benefits. He will think about the negative thoughts about the diet patterns. So that is what the negative feedback loop is always on the minds of a patient. So that is the reason I always feel that before going into any interventions, be it a diet, a nutritionist, medical nutrition therapy, but before each and everything, a psychological counseling should be must for obese patients. Because if a patient is not actually convinced with your diet pattern, with your mode of treatment, he will never ever follow your advice. He will be non-compliant and with poor follow-up, and thereby you won't be able to achieve whatever you thought. That is the most important.
Do you have any different tools under behavioral intervention that you apply to your obese patients?
See, most first things first is actually a physician's. He should actually talk to the patient. A physician should always take a good, proper follow-up of a patient. Whatever is actually the condition of that patient, he should customize the patient's reality. He should customize the patient's financial status. He should customize the patient's mental status, whether a patient is suffering from depression.
Correct. Thank you so much for your inputs. So the next question to Dr. Minal.
For example, if a patient is suffering from irritable bowel syndrome, see it, be it, yeah.
No,
I think the internet is very.
We lost you for a second. Go on, please.
So I'll be quick. So basically, see, if a patient is suffering from irritable bowel syndrome, be it a diarrhea one, but so you won't be able to prescribe the diet pattern to that patient because there's a lot much to discuss about. But a patient of IBS diarrhea and a patient of IBS constipation, the diet pattern would totally be different. So in this actually scenario, a doctor or physician has to play a major role in individualizing the goal setting, in individualizing the treatment mode. That is what I mean to say.
Perfect. Thank you. Thank you so much for this inputs. Now, going forward, in your clinical practice, Dr. Minal, what's the acceptance rate of bariatric surgery if you offer to your patients? And what are the clinical indications or scoring that you do before a patient qualifies for a bariatric surgery? And the last thing, of course, is the role of anti-obesity medications that are coming up before and after surgery.
Dr. Supratik, I think we all have a consensus here on many things, though we are not wording everything. And one of them is that bariatric surgery, though the surgeons proclaim it to be a very big success, but to the general masses and to most of the physicians, it comes only as a last choice. And last choice means when actually the metabolic complications are overriding, not the weight alone, because though we are talking of obesity as a disease, but actually obesity is the mother of all diseases, or I should say the fertile soil for all the diseases. Obesity itself, metabolic healthy person or a metabolic fitness can be one of the targets. It is not necessary that you need to make everybody thin and slim. And at the same time, very thin people, it is not that they are exercising a lot and they are not eating. They are rather hogging at times, you will find, but still they are genetically thin. So, and they are metabolically sick. They are metabolically unhealthy. Their lipid profiles can be bad. Their glycemic control can be bad. So we know that we have thin people who are very poorly controlled diabetics. So the term that we need to re-emphasize is metabolic fitness is our target. And to achieve that metabolic fitness, if the patient on the journey loses weight, it's a welcome thing. But if the patient is not able to lose weight and the patient is not metabolically fit, there are comorbid conditions, uncontrolled diabetes, or there is sleep apnea, or there are other complications of obesity, maybe cardiovascular, though cardiovascular disease once certain will become a contraindication for surgery itself. But otherwise, it is a morbid obese person not responding to any of the metabolic fitness plans, that I will say that we pressurize the patient to go for the bariatric surgery. Otherwise, it's his choice. He can choose to go for a bariatric surgery. Now, the second part of your question, the role of pharmacotherapy. As I told you, everything has a limitation. And just like we have a thermostat, we have a obestat. So we have the weight point in our hypothalamus. If you cut down too much of the diet, your BMR will fall. If you exercise too much, your body will ask for more food and more energy. So our hypothalamus obestat needs to be changed. Otherwise, our obestat will keep bringing us back to the same weight. So keeping that obestat concept in mind, we have to accept that diet, exercise, and medicines, they have their limited role. So these medicines will make you lose some 5% of your ideal, some existing body weight, the present body weight. Your lifestyle modification, diet goes a long way. 90% of the role is from diet, and remaining 10 to 15% supportive role comes from your physical activity or your vigorous exercise also. Pharmacotherapy again will help you by 5 to 10%. Yes, but once you lose weight with your bariatric surgery, or for whatever reasons, that also will come back if you don't follow your diet, exercise, and of course your pharmacotherapy. So for weight maintenance, they go a long way. And for weight loss, they have their limitations, and we will have to accept that. So the target will be metabolic fitness for all. That will be my message.
Right. So perfect. So I think spot on. And we always find it difficult to convince people regarding any surgery for that matter. So they would want to try medications that are available to us before they go in for a surgery. And with the newer medications that are on board, as we said, which has the potential of making you lose up to 30% of the body weight loss, body weight. I think we're looking at great potentials in that respect. and maybe in near future we would not require a bariatric surgery. So
a long way. We have not yet have our own clinical hands-on experience with those molecules. So the pocket-friendly molecules, and still a long journey, I believe.
yes, of course, but we are optimists. We want to see the brighter side of life. So the last question for this panel goes to Dr. Sonali, and we want to hear about the multidisciplinary approach to obesity care.
Yes, that's a best question for the panel, basically, I would say, because it's not just a physician, it's not just a dietitian, but it has to be a multidisciplinary approach, and there has to be many specialists who should be involved in the management of obesity, including the exercise specialist. Most important is a psychologist for the cognitive behavioral changes. And of course, the bariatric surgeon also can be a part of this multidisciplinary team. But one thing is very sure, that looking at the pathophysiology of obesity, it is not one man's game. It has to be done by a team. We have to address the multiple etiologies. If you see the etiologies, it is a genetics, epigenetics, the metabolic factors, then there are behavioral factors, and last comes the environmental factors. So up till now, we had a team incorporating only a dietitian and a physician and a treating physician. But now we need a psychologist, which can be a cornerstone, and then an exercise specialist, and of course, a bariatric surgery for those resistant cases. So yes, it is a multidisciplinary approach that has to be done. And most important, it is not a weight loss which should be aimed, and as Dr. Minal said, that it has to be the metabolic health which we all should be aiming at for all our patients. Thank you.
Sonali, you forgot the leader of the team. Who heads this multidisciplinary team is headed by whom? A motivated patient who should visit us, because we are not going to go to his house any day.
Yes.
A motivated patient leads the team of the metabolic multidisciplinary team, because the patient has to visit us every time asking for weight loss.
Yes, so definitely it's not a physician this time who is at a center. It is a patient himself who is motivated enough for that obesity control.
So great inputs once again. Thank you, Dr. Minal. Thank you, Dr. Sonali. Thank you, Dr. Rajesh. And thank you, Dr. Abhishek, for great inputs. And can we have a felicitation, please? And a big round of applause. So these mementos will be reaching you shortly. Till that. So now going forward, we're now done with the third gear. We're going to the top gear now. Fourth gear is going to be the concluding remarks or the pearls of wisdom. So these are going to be take-home messages for everybody who has joined us today. So we'll go to each of our faculty members so that they can share their pearls of wisdom regarding obesity management, how they have been treating their patients, and what needs to be done forward. At this point of time, I also want to say that Dr. Rutul Goklani, Dr. Amit are there from the PhD group. They're having their program on 12th, and they're very kindly let Amos have a session there. So we will have another representation on that platform. So going forward, first, may I ask Dr. Rutul to please share his views and concluding remarks and pearls of wisdom. So Dr. Rutul is a consultant diabetologist, and we all know him. Can we have the slides, please? Nilamji, can we have the introduction slides? Yeah. So he's the managing director at HC Diabetes Center. Then we have Dr. Prashant Shankar. He's the MD in Medicine and MRCP UK FRCP, and he is again a part of the Moss family, and it's a pleasure to have you here, Dr. Prashant. Dr. Renuka Prasad, who is traveling, but very kindly joined us at the beginning, and he's still trying to join us. He's a consultant at the new Diacare Center. Dr. Dharmendra Pachal is a consultant physician, and he has his special focus on diabetes and obesity and endocrine medicine. And Dr. Sagnik, again, he's traveling and hopefully he'll be able to join us. He's from Kolkata, and again, he has got his special interest in endocrine and diabetes management along with obesity. So first we'll go to Dr. Rutul Goplani for his takes on obesity care.
Thank you very much, Dr. Supratik, for inviting all of us, and many congratulations to you. A wonderful coordination and wonderful program. Hopefully I'm audible properly as I and Dr. Dharmendra are traveling to Rajkot for another PhD program. So we are at one of the mall and we are talking right now. So that was really a wonderful program. And I want to conclude it with that whatever we discussed today, it was really very relevant. It is obesity is definitely a hidden elephant in the room. Everyone can see, but no one is noticing that it is the biggest problem. As recently I was traveling to Uttarakhand, and it is called Pahadi area. We know it is mountains everywhere, but even on that specific airport, I noticed that some of the Europeans were traveling, and I saw that they were so lean and thin, 4 or 5 of them, and all of other people in the queue, Indians, were so fat, and they were unhealthy, and it felt so bad. And I really felt that I'm going to talk about obesity in next few days at FEMO's meeting. So definitely it is one of the biggest problem, and definitely as we have already discussed, it is the reason for many of the disease, like even the cancer, for infertility and many other problems. So cardiovascular diseases. So definitely we need to work very hard on this part, and definitely the future is obesity, where we have to manage lots and lots of patients, and we need to talk more and more about obesity from now onwards. And we are very thankful to Dr. Supratik and everyone who has formed this group. Thank you very much, and I'll hand over to next.
Thank you so much, Dr. Rutul. And now I go to Dr. Prashant, who is with us from the very beginning. So his words of wisdom regarding obesity management, how he deals with his patients, and some take-home message for all of our viewers today.
Thank you. Good evening, all. And at the onset, I would like to thank and congratulate Supratik for bringing up this idea. And as we know, we are in an association which deals with the root cause of almost all the metabolic disorders. And it's nice that we have included obesity, metabolic, and endocrine diseases together as a consortium, so that we can tackle all these things from a single site. And my concluding remarks would be that I have been listening to all the lectures from the beginning, and I had a lot of things to say, but most of these things have been already explained. And what I could see from the discussions is that we are all facing the same issue. It doesn't matter whether you are coming from Mumbai or from Guwahati or from Delhi or from Kerala. The issue is the same, and whether it's the barriers from the physician side, it's the patient's perspective. All these things are the same. I was listening to Dr. Rakesh talking about the patient perspective from his area of practice, and it's the same which my patients tell me, that once the patients lose their weight, they feel that everything is lost. They want to look chubby, and once they lose at least even 1 to 1.5 kg, they feel that something has happened to them. They have some big disease which has happened to them. So that concept that obesity is a disease has to go to the patient and to the public. It's not only to the patient. It's a message that should be reaching the public, and it's we have to educate the public that treating obesity or preventing obesity can help in preventing not only diabetes but a lot of disorders, at least a dozen of diseases, and all these things should be starting from the childhood. So we are dealing with a lot of children who are having obesity. Childhood obesity and childhood fatty liver is a big issue. We have studies from Kerala which shows that from northern Kerala which show that almost 50% of the children are having, adolescent children are having some amount of hepatic steatosis. So all these efforts should be starting from the grassroots level, and that should go aim at more at preventing the entry into the metabolic diseases along with the treatment of the diseases. And whatever from my experience, what I have found is that whatever plan you have to treat the patient, that should be sustainable in the long run, whether it's the diet which we are using, whether it's the low carbohydrate diet or the keto diet, whatever you are using, all these things should be sustainable on a long time basis. And even if you are using the medications, so the medications should be easily accessible and affordable to the patient, because only in the long run we are going to get the benefit. And when it comes to the physical activity also, that again, that should be tailored to the patient. It's not the same physical activity which we can tell to all the patient. A patient with long-standing diabetes and neuropathy may not be able to do the regular brisk walking which we advise to the patient. So again, all these things have to be tailor-made. As the earlier speaker said, we have the patient in the center, and everything has to be tailor-made to the patient's preferences, with proper guidance from the treating physician, with expert advice from the dietitian, probably a physical trainer, a psychologist, and the other experts depending on the comorbidity. So it should be a global approach. It should be a multi-factorial approach which we should take to prevent and treat obesity and the related metabolic disorders.
Great words of wisdom, Dr. Prashant. Thank you for those concluding statements. Now we go to Dr. Dharmendra for his concluding statements and pearls of wisdom.
Thank you, Dr. Supratik, and first of all, really congratulate to you for initiating this sort of event. Congratulations, boss. To conclude, I would like to just say that obesity is not just the energy in and out. We must understand there is a definite genetic background behind that if a person is obese. Second thing, discrimination of a person based on weight must be avoided. To say that it's nothing that a person is having high fat or high weight, and we must say that obese person. I think likewise in diabetes, we say people with diabetes, so people living with obesity is something which will be much more social, that should be accepted. Third thing, as a caregiver, our focus must not be just only to reduce the weight. It must be a weight loss, not a weight loss. It must be a fat loss, which we should concentrate. Fourth thing, in general, we must focus not only just nutrition and this. I think focus, if it is shifted on improving more and more physical activity and make it into the routine, that will definitely change a role. For just example, if we can have in our all the office a buzzer at 30 minutes, and all the patients or those who are in reception, they will just stand up, have some movements and sit down. And this, if we can incorporate this sort of things, and intervention at the school level, particularly educating the children for avoiding childhood obesity and not to become metabolic disease individual in future. So that should be there. So that was from my side. So it's not the weight loss, we must focus on fat loss. Thank you. Thanks.
Once again, great words of wisdom, and thank you all for all your words of wisdom, and whatever you shared. I'm sure it's going to be very, very beneficial for everybody who has been on board today. We had a great session. This is a great start as a family, and we will keep on building on this, and we'll try and reach out in various directions and have more and more of these academic sessions in smaller forms to keep it going. Like maybe once a month, we'll keep having these sessions, and then of course the bigger meetings as it comes. So once again, a big heartfelt thanks to all the faculties who had been here today. It was a pleasure to meet all of you and listen to all of you, and this knowledge that you shared had enriched everyone. So a big round of applause for all of you. Thank you so much. My next thanks goes to Neelamji, Hardik, Nirav, and the entire team of RX Events. Neelamji literally is handling everything today all by herself. And last but not the least, I want to thank Dr. Swarup, Dr. Balaji, Kamaleswari Balaji, Sri, then Vishal, Santu, and the entire team, Obesity, Novo Nordisk, as well as the Impetent team for their support with the academics. And of course, my wife, Dr. Shantani Bhattacharya, was all there around supporting me all this while. So a big thanks to her as well. So once again, thank you so much, everyone. And this is a felicitation for all our doctors who had given their pearls of wisdom, Dr. Rukul, Dr. Renuka, Dr. Prashant, and thank you so much once again, and I look forward to meeting all of you. Okay, so this must be from the RX event. So thank you so much for my felicitation. Thank you. And we conclude the session here, and we look forward to our next meeting. Thank you.
Thank you. It was a wonderful program. Good night, all.
Thank you. Thank you, Anand.
Good night, everyone. Good night.
Bye. Good night.
Thank you.